Okay, in the interest of time, we'll get started. Welcome everybody to the AI-enabled mental health healthcare symposium, a national dialogue. I'd like to welcome you all. My name is David Wilger. I'm the Executive Director of Education Technology at University Health Network and a professor in the Department of Psychiatry at University of Toronto. And this symposium today is brought to you by the Accelerating the Adoption of AI project, which is funded by Future Skills Center. And we're joined today putting on the symposium by CAMH, so this Center for Addiction and Mental Health, and the Mental Health Commission of Canada. The Accelerating the Adoption of AI program is a partnership of University Health Network, the Vector Institute, and the Michener Institute. So on behalf of all of us, we are thrilled to really have this symposium and collaborate with the Center for Addiction and Mental Health and the Mental Health Commission of Canada. Today's symposium is really part of a larger project, Accelerating Adoption of AI in Healthcare, which is looking at improving the mindset, skill set, and tools set of healthcare professionals across Canada, trying to accelerate the adoption of AI. Again, we would like to take this opportunity to thank Future Skills Center for supporting this work, and thank you to the Mental Health Commission of Canada for supporting this work as well. I'd like to say a great big thanks to all of you for the dedication and work that you've continued to do throughout the pandemic. And so thanks to our frontline clinicians and our healthcare communities. It's been a time of change and innovation, and also some respects of struggle. So we appreciate everybody taking the time today to be with us. So a few logistical reminders for the event. So you're welcome to use, and we encourage you to use, the chat function at the bottom of the screen. There is French interpretation is available for today. So to access the interpretation, please click on the globe at the bottom of your screen and choose French, and you can switch from French to English at any point. The symposium is being recorded and will be available in French and English, and you can turn on closed captioning by clicking on the CC button at the bottom of your screen. To stay in touch and to learn more about upcoming events, you can sign up through our mailing list, and we will provide you with a QR code so you can do that. Also, for those who are interested, the workshop, we're excited to say the workshop is accredited as an accredited group learning activity, a Section 1 credit for self-assessment and simulation, as defined by the Maintenance of Certification Program of the Royal College. And our team will be in touch for making sure that you get those credits. So without further ado, I think that's all of the housekeeping for now, and I get to introduce Dr. Gillian Strudwick, who will kick us off for the day. I'm honored to invite Dr. Gillian Strudwick for opening remarks. Dr. Strudwick is a scientist and Chief Clinical Informatics Officer at CAMH. She is a leader in digital e-mental health and a longtime colleague of mine. And when she's not leading e-health, you can often find her exercising, and as I do sometimes, see her on the Peloton. So Gillian, without further ado, over to you. Oh, I should say also a mother. I forgot the most important part of my introduction.
You've defined all aspects of my life, everyone. Thank you, David, for the kind introduction. It is wonderful to be here. Thank you for making time in your busy calendars to both our attendees and our speakers. So today we will explore how AI is breaking into the mental health space. We will hear from some terrific speakers from across the country as they discuss success stories, challenges, and reflect on the impact of AI innovations on mental health patients, communities, and beyond. There's a lot of opportunity clinically and in research and beyond as we think about advancing the mental health space by leveraging the vast amounts of data that we have collected, but we are also continuing to collect. And yet there is a lot at stake. So there's a lot to consider as we do so. Our speakers today are going to touch on the many vantage points of this conversation. Now, before I go any further, I do want to acknowledge and recognize the land in which I'm situated on and where some of you are located right now. I'm currently here, and if I didn't have a virtual background right now, you would see an office space that I'm sitting at, which is located at downtown Toronto at the Centre for Addiction and Mental Health. And so what I will speak to is where I am at, but I understand that we have folks from across Canada and I believe in other parts of the world who are attending today. So CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at that time. And as I said, while some of you or many of you are joining today's event from close by to where I'm situated right now, and what I shared with you now applies to you, I also want to recognize that we have folks from across the country and across the world, and where you're attending from will have its own unique and rich history. So on this slide, I invite you that's present here, I want to invite you to reflect on what you see, and there's also a link to where you can find some additional information. So I'm going to shift a bit and introduce our wonderful moderators. We have two moderators for today's event. We have Dr. Lydia Saquera, who is a mental health informatics researcher and a CIHR Health System Impact postdoctoral fellow at both CAMH's Digital Mental Health Research Lab, as well as Canada Health InfoWay's mental health team. Her work is focused on improving mental health care and service delivery through technology, including studying the usefulness and integrations of mobile apps into care. And I have had the wonderful opportunity of working with Dr. Saquera, and I think you're in for a great session with her as a moderator. We next have a second moderator, Yusuf Sheikh. Yusuf Sheikh is a Master's of Health Informatics student at the University of Toronto, a Vector Scholarship and AI recipient, and is an intern on the Vector Institute's Health AI team. He has interests that lie at the intersection of AI and healthcare as a means of augmenting patient care for all Canadians. And I've had the opportunity of working with Yusuf briefly through the MHI program, so it's wonderful to have connections with both moderators. I welcome Yusuf and Lydia to take the floor here, and I wish everyone a wonderful symposium today. Thank you.
Absolutely fantastic to be speaking, and thanks for the brilliant introduction, Jillian. So we will get a move on, and we will begin by introducing our first keynote speaker, which is extremely exciting. We are very, very excited to introduce Andy Greenshaw, who is a professor of psychiatry and neuroscience at the University of Alberta and a fellow of the Royal Society of Arts. And Dr. Andy Greenshaw trained in Europe and Canada. A fellow of the Canadian College of Neuropsychopharmacology, for which he served as president from 2000 to 2002, and of the Collegium International Neuropsychopharmacologium. Andy has served as the University of Alberta Associate Vice President and has served numerous boards, including the Canadian Psychiatric Research Foundation, the Institute of Health Economics, and is Research Director for the APEC Digital Hub for Best Practices in Mental Health, a digital hub that will serve the combined APEC population of 2.7 billion people. Currently on the board of Mental Health Research Canada, Andy has extensive experience on Canadian Medical Mental Health Research Council and Canadian Institutes of Health Research, CIHR, grant panel since 1989. Andy was a member of the Scientific Advisory Board of CIHR, Institute of Neuroscience, Mental Health, and Addiction from 2012 and 2016. And he was a member of the Scientific Advisory Board of the Royal Institute of Mental Health Research in Ottawa as well from 2014 to 2017, and is currently a member of the Research Advisory Board for Little Warriors, a national organization committed to awareness, prevention, and treatment of child sexual abuse, and board chair for our House Residential Addiction Treatment Center for Men. His active research includes the application of machine learning and data mining to prediction of differential diagnosis and treatment responses in mental disorders. So it is my pleasure and honor to introduce to you all Andy Greenshaw. You now have the floor.
Thank you very much. That's an enormous introduction. I realize I must be pretty old, having done all that stuff. I'm going to share my screen, and hopefully this will work out well. Presentation mode. Can you see my screen? Yep. Okay. A long journey for me in psychiatry and computing science, reflecting, preparing for this really great symposium webinar today. I realized that I've been working with computers formally since about 1973. I worked in the computer industry for a few years early on, when life was extremely different in terms of what a computer is. Land acknowledgement. I want to respectfully acknowledge that I am speaking from Edmonton on the traditional land of the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, and Ojibwe, Saulteaux, Anishinaabe nations, now known as part of Treaties 6, 7, and 8, and a homeland of the Métis. And I've been very lucky in my life in Canada to count many Indigenous individuals as my friends and colleagues. And I'm a member of some of the Indigenous networks, the NEAR network that's funded by CIHR and is doing really good work in terms of increasing capacity and bringing the possibility for improvement to the lives of many Indigenous people in Canada. Disclosures, some of these have been mentioned kindly by Yusuf. I'm on the Management Advisory Board of AMI, Mental Health Research Canada Board, eMental Health International Collaborative, member of the Global Leadership Council, APEC Digital Hub Scientific Officer, two private sector entities, Entheon and EIMHE, which is a digital health enterprise, and the two clinical centers that I serve as board and advisor. Key questions. What can AI do in the context of mental health care? Can we access and harness AI? Who can do this? What are the disadvantages? And is it really worth making AI a priority? I'm fortunate to work in the middle of a computational psychiatry core group based at the University of Alberta, a partnership between psychiatry, computing science, some other departments in association with the Alberta Machine Intelligence Institute. And APEC is the Asia Pacific Economic Cooperation, which has dozens of countries in the Pacific Rim, all leaning in the work we're doing to put forward digital solutions for mental health. In computational psychiatry, we work on illnesses in the domain of mental health, whole list of them. The kind of data we use, very varied: genetic data, imaging data, neuropsych data, human speech, health records, We work with clinical trial data, 2 examples of Pfizer, National Institute of Mental Health, various public domain data sets. And our goals are really to use machine learning / AI for diagnosis, prognosis, and to generate clinical tools. Thinking about the journey so far, things have changed a lot, and many people who are listening to this webinar will not remember a time before the internet. Society's been more or less completely dependent on computer technology for most of the world, at least since the 1970s. And cultural acceptance has been progressing. Rewards have outweighed concerns for many members of the public, especially since email became available, the internet became something that was publicly used widely, and the development of smartphones that have connected people to email and the internet very intimately. The image on the left is a plug for a book called Afterthought by James Bailey. For those of you who are interested in the rise of computing and some of the fundamental impacts it had on society since the beginning, it's actually a very good read. If we look at the rapid rise of AI and machine learning, this is illustrated by a simple count of publications from PubMed, which is primarily medical sciences database, as you know. And I've looked at papers from 2000 to 2021. You can see the exponential rise since around 2010, when we started engaging in using machine learning to address issues of mental health. So over 25,000 publications have accumulated. And that's a very conservative estimate because this will not catch everything. Machine learning. We talk about AI. The term AI has changed very much over the years. It's become popular, general use. Really, AI is a branch of artificial intelligence research that uses computational models capable of learning patterns to make predictions with machine learning, combined into something that is an entity that is directed to achieve certain goals to some extent autonomously. So machine learning is the fundamental basis of AI. And we have a diagram here that shows us more or less the complete complexity of the domain of machine learning, notably supervised or unsupervised and reinforcement learning. Around 2016, 2017, this really started to hit the press. A couple of articles here, Time, very prominent, October 6, 2017, how robots are changing the way you see a doctor, machine learning, and the profession of medicine in JAMA, another very prestigious medical journal. The public really caught sight of what AI could do when DeepMind and colleagues put together the AI entity AlphaGo Zero. AlphaGo is an entity that learned to play the game of Go, an Asian game of great complexity. AlphaGo Zero was an entity that learned to play Go with no instructions at all, no historical data, and within 40 days had achieved asymptotic performance, beating all other software that had been designed for this and easily beating all human contenders. This was an example of how a machine could learn a very complex set of information and use it strategically to outperform everything else. The significance of AI now, this is a slide borrowed from my close colleague Russ Greiner in AMI and computing science at the U of A. We have all of the things we need potentially to do work on every aspect of many things in the world, particularly health. We have online data, records, telemetry from equipment, databases, medical records, new algorithms and theory. One of my colleagues has suggested that to achieve the things we'd want to do, we probably have all the algorithms we need already, although Things are moving forward all the time. There's massive computational power available, and there are networks of high-speed machines which are increasing in capacity and speed all the time. And there's a very fast industry growth. People realize that this area of engagement can generate a lot of funds for people who are in the for-profit business and achieve savings for those people who work in areas where they're trying to make things more efficient and affordable. Human thinking, 4 dimensions at most, 3D space plus time, machine processing, multi-million dimension approaches. For imaging studies we typically constrain our analysis to a 70 million dimensional space. Impossible for a human brain to do that. New methods, large complex system analysis, enabling the management and more ambitiously, perhaps the understanding of higher order systems. Social preparedness for this is a big issue and something that will be discussed a lot today. There's a lot of potential for AI in health, but there are lots of cultural issues that will come in. Machine learning and AI are leading us into unknown and exciting territory. 3 steps to understand this. It's probably familiar to all of you. Data mining, you're extracting data features from databases. Machine learning, it's automated learning about clusters of data associations and how those features are organized and interrelated. And AI is putting those elements together to achieve something at a high level of complexity. The value of machine learning is that with large high dimensional data sets, when you think about all the labels in a health system, all the features, machine learning is actually necessary to make sense of the data. We can go quite a long way with traditional multivariate methods, but nowhere near the level of analysis to be achieved by machine learning. Technology applications in AI, we seem to be faced with 2 options. So this figure contains 2 people, Russ Greiner, my close colleague, and Mira, who was a postdoc now working in industry, Dr. Gerritman. Russ always talks about data-driven and black box as a position. If you work out something in the health system and you get the solution you want to make the right decision for a patient, do you really need to know why or how? Mira, on the other hand, was always interested in theory and knowledge-guided things, having a thirst for understanding. Russ is also interested in that. I put this counterpoint together because of listening to these 2 people voicing these 2 positions. This is an issue in the clinical space because many clinicians want to know how it works and why. And it's a bit of a cultural change to realize that if you have an algorithm or an AI entity that can make a decision for you that's reliable and better than the human decision-making process, even if you don't understand how it reaches that decision, the patient will benefit from that optimized decision-making. This is a cultural issue. A lot of people want to understand. Some of the technology applications here involve things that people actually cannot understand. We can understand the principles, but we can't understand the actual mechanism because we can't operate in a hyperdimensional space. The Harvard Business Review on October the 18th, 2019, big piece about adoption of AI in healthcare will be slow and difficult. I gave a paper in China around that time and I put a highlighted line around and put this banner up saying no. Why did I do that? Because things are progressing anyway. In Canada, on the same day, here is an internet screenshot from TELUS putting out the beginning of Babylon, which is an attempt to move towards AI with an integrated healthcare package. There are many such examples of that are moving along. They're not delivering what we know they can eventually deliver, but they're in the marketplace and they're going concerns. Resistance to change, especially among health professionals. People like the things they know, people like change, but generally they like things to change back to what they know and what they're comfortable with. COVID forced society over the digital divide. And now we're in a place where we've been forced to use technology during the very difficult times of the pandemic for access virtually and for decision-making at a distance. And so many people in the clinical space are now using digital technology very well. There are huge potential advantages to rapid developments and AI implementation. There are huge opportunities to get ahead of the curve, and many developing countries are really taking advantage of that. Through the APEC domain, work with a lot of different people. There's a move at the moment in the Philippines to develop digital health, and I'm on a committee with a national panel that are about to engage in a world consultation. Will be in Canada in the fall. We know the economic burden of mental illness is huge. There was an estimate of one of my colleagues that it was $51 billion a year for depression, adjusted Canadian dollars. It's now about $80 billion a year. Here's a paper from Toronto's own Jürgen Riem and Kevin Shield on the global burden of disease around that WHO issue. Health priorities. We need accessible, efficient treatment and care options. And the big question is, will AI and machine learning provide solutions? What can AI do? AI basically does prediction. Here are some standard receiver operating characteristic curves. The further this curve pushes up to the top left-hand corner, the better the prediction is, looking at true positive and false positive rates. This is an illustration of how you use different algorithms, you get different performance. It's not one size fits all. There are different approaches and techniques depending on the nature of the data that you have. Problems with AI technology, data access is a limiting factor. People often joke about working on the records from the same 200 people of the same cultural group. Data access is getting better. There are ways to integrate with larger data sets. International collaboration is one way that we've been doing that. Beware of claims of high predictive accuracy. Overgeneralization is a problem. There's an obsession with accuracy and specificity, but I would say you're really looking for performance that is not inferior to humans, an advantage doing predictive work that's improving the output of humans is an advantage for patients. Validity is dependent on the data sets used for training and validation. And unless you have the right data set, there are questions around applicability and generalization. And I know Gillian is an expert on health implementation. And in this area, I always think about efficacy versus effectiveness. Machine learning and AI are really well adapted to real world data and the complexity there, looking at individual cases in a field of many, many data points and a lot of variation. How can we access and harness AI, and who can do this? Large data sets are needed to approach a health domain problem, and we need teams of people. Clinician involvement is crucial, again, interprofessional teams. People always wonder about, how am I going to do this AI thing? I don't know how to code. I don't understand these things. Computing scientists who purely do coding, they don't understand the health domain. It's really an interprofessional collaborative activity. This is a smattering of papers we published over the years that use machine learning / AI. I don't have time to talk about many of them. There's towards artificial intelligence in mental health by improving schizophrenia prediction with multiple brain parcellation ensemble learning in Nature Schizophrenia. A lot of this stuff is really cool science. Big question is the cool science, how applicable is it to patient care and the health system? We definitely want to do the cool science to learn more about diseases and more about how things work and what goes wrong. But we really want to use this for predicting early onset, identifying patients who will be responsive or non-responsive to treatments, and differentiating between different subtypes of disorders. Here's another one using large Chinese data sets in collaboration with Li Tao from West Sichuan Hospital at that time, looking at the difference between first episode schizophrenia, healthy controls, major depressive disorder versus healthy controls, and between the two. Early days, the percentage accuracy was not great, but these were good beginnings back in 2018. A lot of fun is to be had in this. Here's Russ Greiner and Sunil Kalmadi that we recruited from NIMHANS. There's a brilliant young colleague. You can see the topic is whose brain is that big. This was part of a German film crew who came to do a documentary on our work. Jeff Sawala, who's looking there like somebody from Hollywood, actually does star in movies, but he's a machine learning expert, one of our PhD students, individualizing identification first episode bipolar disorder using machine learning and cognitive tests. This is an interesting piece of work, applying machine learning on a battery of cognitive tests to look at first episode patients, originally training the algorithm on chronic bipolar patients, and then using the model to identify first episode patients with an accuracy of 76%, 77%, and indicating these cognitive deficits are markers that can be used, and maybe they're enduring in early and chronic bipolar disorder. This is something I want to focus on a little bit. This is Chao Boer, who calls himself Cloud. He's a Canada research chair that we recruited in a couple of years ago. A brilliant person trained in math, computing science, and neuroscience. And he has done some great work with public data sets looking at opioid use disorder. The big frustration is you can't get enough access to data. So Cloud talked to Alberta Health, and they employed him for no money so he could go behind the firewall and have access collaboratively to 4.5 million cases. And this is part of the work that we've been doing together, individualized prospective prediction of opioid use disorder, just accepted in the Canadian Journal of Psychiatry this week. Ensemble machine learning trained on a cross-linked administered health data set, different data sets in Alberta. There isn't just one, of course. Validating it on a holdout sample. So it's 2014 to 2018 cohort, and that's validated. And then the prediction was done on a 2019 cohort. It's a bit like you're looking at future prospects by taking different slices from a historical timeline and coming out with a high accuracy and specificity. So accuracy of 86%, identifying opioid use disorder cases. And this work includes predicting overdoses, very relevant for the current crisis with fentanyl and opioids. Very balanced set out of this large possible number. You look at the N for opioid use disorder and non-opioid use disorder, imbalance in the numbers. This was handled with appropriate sampling. Very good balance with age and biological sex. One of the issues that comes up is everyone wants access to the health data, but the health data in administrative records probably don't have the things we want. And we have to have a conversation with policymakers and the data czars of the health system to talk about the kind of measures we really need. More detail on that. So here you can see the accuracy, 80%, 93% of true labels for opioid use disorder or non-opioid use disorder, and there's the ROC curve. Potential of machine learning. Electronic health records allow access to population level data. And machine learning allows a personalized approach. You can do this analysis, look at an individual person and generate a prediction for what the probability of that person having a disorder or changing from state A to state B is. John Torres and colleagues. John is, I think, the guru of digital health in the US, the APA lead on digital psychiatry. Published a lot on apps, social media, chatbots, and virtual reality. I really recommend John's papers to you all. He has been in Toronto a number of times, actually a Canadian. The future is here. Use of internet apps is universal. John's been very critical constructively about the quality of apps, and smartphone use, of course, is everywhere. This is Tmall Genie, which is a Chinese chatbot, remarkably effective with visual sensors, auditory sensors, and able to speak. There's a great video from Alibaba who created this, where there's an old lady in Beijing who's being supported in her apartment, having a conversation with the chatbot that's asking her about, did she take her medication? Where's she going? Would you like me to call your daughter? And don't forget to take your umbrella because it's going to rain this morning. Talking to an American cardiologist about this at an American meeting, he said, wow, my mom's 95, I need one of these. And I said, does your mom speak Mandarin? Well, no. Well, it's there for the development. There are Canadian efforts. This is a chatbot we're developing with the Mood Disorder Society of Canada, MIRA, a chatbot for mental health resources. The beta version is out. If you want to test it, we're happy for you to do that. It is directed currently to healthcare workers to provide support and navigation for healthcare workers looking for information to deal with issues that they're dealing with for themselves or their families. Virtual reality is another possibility that will explode in the future. Here's me wandering around in China in a virtual space. This time I'm on the 96th floor of a skyscraper, and I'm supposed to walk out on a little walkway to rescue a kitten, which, being a climber, I was able to do. And they were very shocked because everybody's terrified when they get out into that environment. The digital clinic, this is something that John Torres established in Boston that came out of the needs generated by COVID. This is the kind of context we need. And you can find this in a number of papers, for this one's in General Hospital Psychiatry from 2020. The individuals here you can't see, me as the patient. We have a psychiatrist, a digital navigator, and another clinician, and possibly a family member. Apps. There are good apps and bad apps. John has got a website where you can go and find out what the quality of apps are. Reason I put this up is that FDA has issued position paper on AI machine learning based software as a medical device action plan. And Health Canada and the National Health Service in the UK are moving forward in that direction. So AI-based solutions for health, what are we looking for? Can we access appropriate data? How do we choose data and achieve data standardization? Privacy and confidentiality are everywhere. I argue with people that the horse has already left the stable because people sign up for browsers and give all their privacy away without knowing it. I was talking to a bunch of bankers a year or so ago, and I asked them, do you do internet banking? And of course they do. And I said, do you care more about your health data or your money? Well, most people would immediately go, my money. So there are solutions to be had, but again, it's cultural change. We do need to take seriously the whole issues of ethics, privacy, and confidentiality. But rather than see it as a massive barrier and be overprotective, we have to think about ways in which we can do things that are good for the people and the health system. Quality of data is important, nature of data. The old engineering adage, garbage in, garbage out, applies here. Training and algorithm choices are important, validation is important. How do we achieve data standardization in a very diverse field of data domains? It's a bit like the old railway gauge system in Europe. Everybody has different width tracks. What do we do with the results? There have to be ethical discussions about how results are used and how useful is prediction. Suicide is an issue here. If you were to predict suicide risk, it's been discussed at length. There's not much you can do if you make a prediction. One of my Indigenous friends said, I'm not interested in suicide. And that shocked me until he said, I'm interested in determinants of health. And I'm reminded of Desmond Tutu's very famous statement that We keep pulling people out of the river. Maybe we should go up the river and find out why they're falling in. So doing some reverse engineering on data around suicide risk might lead to determinants of what leads to avoidance of those states. That leads to analysis of emotional regulation and family context and so on, all accessible through machine learning. Prospective data is optimal. We look historically at lots of databases. History is interesting, but not as interesting as the present and what will happen next. Demographic, natural language processing is amazing. Imaging is great, but not really accessible. Natural language is accessible to everybody. We're doing work on PTSD identification just with language. One last thing I'll say is that I think indicators of health quality are super important. This is one of my favorite matrices. This is from the Health Quality Council of Alberta. And at the top, all of the things we talk about in the conversation today: acceptability, health services are respectful and responsive to needs, preferences and expectations of people with lived experience or living experience and their families. Accessibility. The whole thing about digital is it can be so much more accessible for urban, rural, and remote. People can be isolated even in the city. Appropriateness. Culturally appropriate. Is it appropriate for the kind of person? Is it effective? Is it knowledge-based, evidence-based? Is it efficient? And the big one in terms of EDI, is it safe? Mitigating risks, avoiding unintended or harmful results. Take-home messages. AI is already here in all areas of life. Potential exists for accurate and reliable personal predictions based on big data. There's a flood of apps. Be careful, regulation is difficult. It's really important to recognize this area as a team sport. Not everyone has to be able to code. Equity, ethics, and privacy are key factors for success. Buy-in by users, patient, family, and healthcare personnel must buy in for effective implementation of positive health outcomes. High-tech measures like imaging are useful, but scale-up requires access, and the cost has to be right. Natural language processing is an amazing resource that will be increasingly used. And archival data are of interest, but streaming health data are the future. So the key questions going back: what can AI do? It can achieve transformative change. How can we access and harness AI? We have to collaborate with experts in different domains. Who can do this? It takes a village, interdisciplinary teams. And what are the disadvantages? There are cultural challenges. They look like disadvantages, and we have to decide as a civil society how we will do things and how they can benefit us, taking into account all people, including marginalized and vulnerable population. The Mira chatbot that I mentioned earlier, we are building that in collaboration with Indigenous partners. So the idea is to roll it out in the Indigenous space according to the wishes and requirements of Indigenous peoples. Is it really worth making it a priority? Yes, for the goals of access and equity, for sure. My compatriots, wonderful colleagues, senior professors, postdocs and research associates, we have a whole host of students and collaborators who are amazing. And there's beautiful Lake Louise. Thank you very much for listening today.
Thank you so much, Andy, for taking us through your journey and also the larger, journey of AI right from the 70s. It's kind of lovely to see the rise in significance of this technology within all spaces, but specifically within the mental health care space. And I think you've got us thinking, at least myself, about some of those important considerations, such as the cultural, social preparedness, nature and the quality of the data, and the importance of interprofessional collaboration and really usefulness of prediction. So I think we have time for one quick question. I know you'd mentioned studies about predicting early onset for outcomes such as depression and bipolar disorder or opioid use disorder. Where would you say the field is at with these kinds of projects? Are we still kind of in the development phase, or have we moved to implementing these and kind of providing clinicians with alternative treatment recommendations? Or I guess in your opinion, what are the steps required to get there?
Well, we've demonstrated, and other groups have demonstrated, this can be done. All of these things can be done. Everything is dependent on the kind of data you can access. And at the moment, we are looking at archival data. So we're looking at large data sets. We're in Alberta, we're looking at data that have been recorded and compiled by the health system. So it's still not streaming data. And we've demonstrated that with the limitations of administrative health data, we can make these predictions. It's super important. Everybody in psychiatry and in mental health care professions understands that the earlier you can intervene, the better chance you have of mitigating symptoms, maybe preventing disorders from blossoming. That's an odd word to use. The big problem, Lydia, is that we don't have the data that we want in the system. Databases are fragmented. And you look in the Toronto area, as many of you know, there are many different databases from different hospital systems. Alberta ostensibly has one healthcare system, Alberta Health Services. We have numerous databases. And in clinical practice, I have fun joking with my clinical colleagues. One of my psychiatry friends that I do collaborative work with, we were talking about clinical practice, and I turned to her and I said, Lisa, so in your office, what do you measure? And she looked at me like, well, I don't. It's global, clinical global impression, or, you know, what I think about symptoms, I'm not measuring it. Why not? Because the system doesn't have measures that are standard and mandated. And we know from NICE and other entities that the consultant's opinion, although interesting, does not constitute firm evidence about the progress a patient can make. So we actually need convenient outcome measures embedded. It's not just psychiatry. There are all areas of medicine that need improvement. In psychiatry, generally, there are very few outcome measures that are captured by the system. So we look at things like ICD or DSM codes for what was wrong with the person to secure the diagnosis, and we look at prescription records or clinic visits, but we don't have that phenotype captured in the clinic office. We do that in the research context with, there are all these brief self-reports, PHQ, GAD, lots of different things we can do, but they're not part of the health system. And the health system generally will tell you, we can't afford it. Clinicians will say, we don't have time. It's a question of cultural change, setting it up so we can make those measures, so we can understand the clinical space. Doing that will basically set us free. And if we had streaming data, we could catch people before they fall. That's a big trust issue for society. I think that's a huge point for our conversation today. Personally, I would love everybody to have my health profile going into an AI sentinel system to say, his mood's okay, he's not behaving strangely, he's not spending too much money, driving fast, doing things that are out of balance, he's not hypomanic or manic today, he's getting to work, he's not absent, work interactions are good. We're actually working with people in traditional physical medicine. I always think of psychiatry as part of medicine, but there's that dichotomy. So that we're talking about putting remote sensing on people with wearables and tracking their physical and mental health together. They're not separate. The valley between the focus on physical and mental health is amazingly empty and fertile, and we need to go there. Streaming data, imagine how great it would be if you knew that your teenage child was behaving in ways that weren't typical, before you noticed, or that your partner was doing things that didn't make sense with the normal track. At least you can go and look and do risk management. Privacy is important, but helping people who don't have insight and are struggling and about to spiral down is really important. Anyway, I had lots of stuff to talk about today. We could be here for a week.
Awesome. Well, thank you so much again. That was a wonderful, great start to the event. And I know there's a few questions that have come in since, but we'll definitely get to those in the moderated discussion section after our panelists speak. So I'll pass it on to Yusuf right now.
Yep, thank you, everyone. We got a flurry of questions, so keep them coming. But we understand that Zoom fatigue is a thing, and we've experienced that for about almost 2 years now. So we're going to be giving everyone a stretch break till about 12. So everyone can maybe just recaffeinate. I know that I'll be doing that myself as well. So everyone, please come back around 12, and then we will be doing a little interactive poll and then introducing our panelists to you as well. So see you all then. All right, welcome back, everyone. Now we will segue into our panel presentations, which I think will be very, very interesting, given that the audience is already so engaged. But prior to beginning our panel presentations, we kind of wanted to understand what's the pulse in the room by performing 3 simple polling questions. So you guys will see a poll that will pop up. So you'll see 3 questions. What is your role in the healthcare community? What is your level of experience with AI? And in which aspect of your work do you think you need the most help in advancing AI? And if you could answer all these questions, it would be greatly appreciated, as we can tailor the moderated Q&A to your interests, as well as making future events better for the respective community. So I'll give you maybe 30 more seconds. And we will then begin our introduction of the panelists as well. All right, perfect. Okay, everyone. So now it is time to introduce all our panelists. I will introduce the first 2, and then Dr. Saquera will introduce the last 2, and then we will segue into our first presentation. So our first panelist which will be presenting to you all is Niraj Bhargava. He's the co-founder and lead faculty of NewEnergy.ai, a board trustee and chair of the innovation committee at the Royal Ottawa Mental Health Center. Niraj is a co-founder and lead faculty at New Energy. Great, you guys can see the poll results, awesome. And New Energy essentially specializes in artificial intelligence governance education, creation of organizational level ethical AI frameworks, and integration of AI trust measurement software, which is also known as the Machine Trust Platform. Niraj has over 30 years of experience in technology, business creation, and leadership. He's a serial entrepreneur and has successfully been the CEO and founder and leader of technology companies focused on AI, machine learning, and deep neural networks. He is currently the chair of the Innovation Committee of the board at the Royal Ottawa Mental Health Center and has been member of their board of trustees for the last 5 years. In the past, he has served as a dean, a university professor, and an executive at General Electric, among many other prestigious organizations. He holds an MBA, a degree in system design and engineering, and completed the director's education program leading to his PhD degree and his ICD designation. And he has also been a prominent speaker globally on sustainability on ethical AI. So it is my pleasure to introduce Niraj to the stage right now.
Hello, everybody. Thank you very much, Yusuf. I appreciate the introduction, and it's a real pleasure to be here in this very fascinating and important conversation. I'm going to try to share my screen and have some opening remarks before the discussion that I look forward to us all having. So let me just make sure this works for all of us. Right, so can we see my screen? I think we should.
Yep.
Great, excellent. Yes, so I really appreciated the opening presentation by Dr. Greenshaw as well, and I'm delighted that there's so many people with this important interest in AI and mental health care and its application. I think there's tremendous opportunities, and as my cover page says, and was identified in the opening speaker, there really is a powerful technology and capability with machine learning and AI that really can be applicable to mental health care. But I'm going to come at it a little bit different in my opening presentation because, as mentioned in my introduction, our company, New Energy AI, and a lot of what's going on also is the recognition that we need to build trust in artificial intelligence and machine learning as we apply it into mental health care. So I'm going to discuss a little more about AI governance and why and how we can build trust as we look to take advantage of these technology opportunities in mental health care and building trust. So with that, let me just make sure this works. I'm going to start with a little bit of a lived experience. A few years ago, I'll share that I had a personal situation where a best friend and I went out for a social interaction. He was supporting me in a number of things that were going on in my life. And surprise to me, a couple of weeks later, I got a call from a family member saying that he had taken his life and had committed suicide. We had an understanding that if anybody was feeling that they needed support, they could reach out to each other, but that didn't happen in this situation. When we talk about the importance of all the great work in mental health care, I think we all know that these situations in the lived experience and friends and family, we really want to get ahead of the curve on what we can do to support people in such situations. So the slide I have up is a recognition that there is a lot of activity in social media, and there is machine learning and AI that can look across social media for suicidal ideation cues, and whether we can have some early indications that people may be more significantly concerned in their mood, and something that we may be able to help address and support earlier on as well. So clearly there, in my situation here, we would have loved to have had some early indications of this situation, as would his family, and that didn't occur. Could we consider scraping and understanding social media data for identifying, using machine learning, mental health issues and cues? And in this use case, there is great research going on. I'm happy to follow up with people on people I know that are doing great research in this area. And we would recognize that there is application and need, but there also may be some questions about if and when and how would we use such machine learning models, because there's ethical questions that come up, there's privacy issues that come up, and there's bias issues that come up, amongst others. So we definitely have a power of technology that can be applied, but we do need to consider how best to do that in an ethical frame. In preparing for today, I was delighted to see some of the early findings of the Michener Institute and the sponsors and organizers of this event. And I also coupled that with recognizing as a board member at the Royal Ottawa that there is some mandates and strategies about access, hope, and new possibilities in mental health care. And when we look at some of the opportunities with AI, clearly the potential of AI can really deliver on the hope dimension by early diagnosis, identifying effective treatments, identifying and improving in treatments. And then on access, clearly there's an opportunity to use advanced technology, machine learning and models to reach those that are in need of medical health care and prioritize from a wait list perspective or from an understanding of who can use the support of mental health care. So clearly there's an opportunity in this important mandate we have in mental health and the care we want to provide our communities. So as Dr. Greenshaw shared, there's some technical definitions and understanding around machine learning. I'm going to briefly talk again about the key aspect of AI, that a lot of what's happening today, AI is no longer the future, it is all around us. And as Dr. Greenshaw mentioned, legislation and other kinds of safeguards may not be keeping up with AI, and there's opportunity for us to move forward and use AI, and we just need to think about how it's being used and when. So in this diagram I have here, I identify that when we talk about the life cycle of machine learning, there's a number of stages that we need to recognize. There is large amounts of data to be collected, to be cleansed, to be pre-processed, to be classified. And that data preparation is a significant effort required to building effective models. And there's lots of model building, iteration and development and performance and false positives and negatives that need to be measured before you have a model and before you can start applying that model. Well, not all of us are technically going to be experts on the technical depth and nuances of machine learning and AI, but we take it up a level when we think about oversight, and we recognize that the stages are really around data, around development of models, around deployment, and there's a fourth D called drift, which recognizes that there may be unintended consequences of AI as well. So we need to think about the life cycle of AI when we understand its application. We have lots of examples. Again, Dr. Greenshaw did a great job on identifying numerous examples of machine learning being applicable in mental health care. Lots of research going on. I identify one that was mentioned earlier in diagnosing PTSD. You know, clearly today's climate is often using clinicians to use subjective interviews on patients and patient self-reporting to get early cues and early diagnosis and treatment for PTSD. Well, machine learning has come a long way with natural language processing and ability to look at voice and text and be able to identify early on measures and be able to identify and have some prevention or some early diagnosis that can really address some of the PTSD kind of outcomes that we really want to get at early. So clearly many applications, but I'm going to step back a level in my opening remarks and identify that, you know, we've had many waves of advanced technology over all our careers, and we're seeing them now, and there's more to come. But what's different about AI? Well, we're at a situation now where technology is now advancing and learning faster than people. And so we're at a point with the great breakthroughs in memory and capacity and in processing power and data that we can now adapt and learn faster than people. And we now can empower technology to either augment or make decisions. So that is a tremendous opportunity for these difficult and challenging questions in society. But in parallel, when we start empowering technology to augment or make decisions, the question of trust comes up. And we've been dealing with human trust forever, and we're working on it, and we've made good progress. But when we talk about machine trust, there is a gap that we need to recognize, that we are now in a situation, again, this is not in the future, this is today. Do we have the trust of that AI and machine learning, and what can we do? Because you're going to hear, while I'm going to talk about some risks, I'm also an advocate that there's opportunity that we should seize to utilize AI, but we need to think about AI's trustworthiness in parallel. And I know you all know there's many examples in healthcare, but outside of healthcare, of specific issues and concerns around the trustworthiness of AI, whether it's privacy issues and informed consent we talk about in healthcare. You know, yes, we all click that I consent box on our social media, but do we really, is it really informed consent of what we're allowing people to use in our data? Ethical questions of the purpose of these models, and are they being used in ethical ways? Bias is clearly a significant issue. The training data may or may not be a good example of the target data that we're serving. Transparency, black boxes. Sometimes it's okay to have that performance and use deep neural nets that have a lack of transparency, but other times we need to be able to explain how an algorithm made a decision. And good governance. I'm going to take a quick moment to step outside of healthcare and use an example that our company, New Energy AI, has experienced in looking at another industry, law enforcement. And a couple of years ago in law enforcement, there was a recognition that AI could be very applicable for identifying pedophiles, terrorists, criminals. But last year, the Privacy Commissioner of Canada came out and said facial recognition technology should no longer be used in Canada, and the RCMP and the Toronto Police and Ottawa Police were no longer allowed to use facial recognition after they had initiated some opportunities to use that technology. And so the question in law enforcement is, it's all about public trust. And in healthcare, it's all about public trust. And so public trust is fragile. We've spent a lot of time in healthcare building trust in healthcare, and we don't want it to fall when we inappropriately apply some new technologies without considering the governance, the transparency, the understanding of what we're doing, and having some communications with our stakeholders. So I'm here to say that we need to consider the guardrails, because we're recognizing in parallel to the opportunity of AI that we need some actions around the risks to human rights around AI and machine learning as well. So our company, New Energy AI, is one of the companies that is focused on the governance of AI, education, building frameworks that are specific to organizations, and having some transparent software that can have some oversight and some metrics and measurements about how we're looking at that AI lifecycle. Because when you're going through those stages of building a model, we need to understand the risks and the impact levels along the way. And we have to recognize the traceability and the consistency of application of ethical standards across the life cycle. And one of the challenges, as identified in this diagram, is that it may not be one organization involved. There may be multiple organizations in the pipeline as we look at the development and deployment of AI. So we would like to encourage upfront, as we look at AI in mental health care, the development of guardrails and making sure that we know what's within acceptable guardrails of how we use machine learning and AI, and what may be outside, and what may be in the yellow zone or the proceed with caution. So one way we do it, and I'm proud to say as a board member of the Royal Ottawa, that we can create frameworks for governing advanced technologies in AI. And that's something that we did with the Royal Ottawa with New Energy AI, is we created a framework, a trust framework for AI. And there's many models existing around the world. If you Googled AI trust frameworks, you'd find many frameworks. Most nations have frameworks in their governments. Well, we have frameworks in healthcare as well. One identified here, looking at fairness, transparency, trustworthiness, accountability. So there are governance models, and we need to have that oversight. When we polled people in healthcare and mental health care a couple of years ago, there was a recognition that our guardrails were really at a scale of 1 out of 5 when we need them to be 4 out of 5. So we're encouraging that let's put these guardrails up early, up front. And in the case of the Royal Ottawa, there's a recognition that we need to have inclusiveness and avoid bias. We need to have some transparency. We need to have performance and quality, and we need to have some privacy and destigmatization in our AI. And I was delighted in that framework. We had the voice of clients and families speaking up with the questions that they raise early, so that we can have some transparency and trust as we move forward with this important area. So those are my opening comments. Thanks for your time. I look forward to the discussion and any questions you have. Over to you, Yusuf.
Perfect. Thank you very much for that presentation. I love the governance aspect of AI. I think we all understand that AI is a multifaceted kind of beast that we have to tackle, and it was great to hear that perspective. So now we will be transitioning to another perspective, and it's my pleasure to absolutely introduce Elisa Simon. Elisa brings more than 20 years of leadership experience in healthcare access and nonprofit management to her role as Executive Vice President, Innovation, and Chief Youth Officer at Kids Help Phone. In this role, Elisa oversees Kids Help Phone's national clinical service programs, provides strategy, leadership, and guidance to more than 150 clinical staff and thousands of volunteer crisis responders across Canada. Through her focus on building innovative digital systems that break down barriers to care by changing the way care is delivered, measured, and received, Elisa is driving the transformation of Canada's youth mental health landscape and creating equitable access to support for youth across the whole country. Under Elisa's leadership, Kids Help Phone has evolved from a phone-based helpline to a comprehensive solution that fully integrates a growing number of access points, programs, and resources, achieving a record 4.6 million interactions in 2021. Elisa oversees also knowledge translation, quality assurance, and equity programs, ensuring the organization is delivering the best possible services to young people, like myself, hopefully, particularly youth from equity-seeking communities. Elisa also holds a Master of Public Health degree from the University of North Carolina, and it's my pleasure to introduce her as our second panelist of the evening. You now have the floor, Elisa.
Thank you so much. I'm going to try and share my screen, so give me 1 second while we hopefully get that to work. Okay, can you see that?
Yep.
Perfect. Okay. Thank you so much for the invitation. I'm really thrilled to be here. Although this background, I'm not sure what's happened with my hair, but that's for another day. Thank you for the introduction. As I said, I am with Kids Help Phone. I'm going to start with a quote because that's what we always do at Kids Help Phone, to ground ourselves in the young people that we serve, the reason why we build everything, the reason why we exist. So I'll give folks just a second to read that. I'm also just going to quickly touch on who Kids Help Phone is and why would we ever be invited to a webinar symposium talking about AI. Kids Help Phone has been around since 1989. We consider ourselves really pioneers in virtual care or e-health solutions. We were doing this before any of those words were really known, by the fact that the very first time we opened our doors, young people were calling in to connect with a professional counselor. And over time, we have grown. We continue today to be the only national bilingual 24/7 service. We provide anonymous and confidential support, counseling, information, and referrals, as well as peer support. There's a whole wide variety of services, and we provide them to youth as they define themselves. So there's no upper age limit. Basically 5 to 28 or 30 is about our age range. But again, why? Why would we be talking about AI and e-mental health and all of these kind of cutting edge things that we're talking about? And the reason is, it was touched on early, how quickly technology is changing. I'm here also to say that young people are changing almost as fast. And so we realized a few years ago that if we were going to continue to serve young people in the way that they need and that they expect, that we had to try and keep up. We had to be able to build scalable solutions because the demand is constantly outstripping the ability for our systems in mental health care to actually meet the needs. And it was no longer enough for us to say, oh, well, we answered a percentage of our calls and some we didn't. That wasn't okay. It wasn't okay to say, yeah, well, some young people are going to be on waiting lists for 3 months, 6 months, 9 months, or maybe they'll be waiting for us for an hour. And so we really, about 4 years ago, put a stake in the ground, developed what we call our innovation imperative that said that we were going to be focusing on building scalable, high quality solutions to provide supports to young people across a wide spectrum of needs, and leveraging the technology that was available to be able to do that. So that's kind of why I and Kids Help Phone is here today. Since the beginning of the pandemic, we have had over 11 million interactions with young people. That is a huge increase from before the pandemic, but it's not only because of the needs of young people, it is also because of that commitment to those scalable solutions that I was talking about. And the reason I'm mentioning this 11 million is not to brag. It's because of the conversations we were talking about earlier about the incredible importance of data. Because you cannot build tools that use technology or AI or ML without data. And so 11 million interactions means that we have a tremendous amount of data. So this is kind of where our data comes from at Kids Help Phone. Along the top, you will see the different types of services that bring us data. So we have texting, we have counseling. So all of those are up on the top. And then underneath that are the kinds of data that we are getting. So we have service user data, and this includes any profiles they create, user behavior, surveys that they fill out after every service, as well as the one that I think is most important when we start talking about AI and ML is the conversation data. So we have 28 million texting messages just in our texting database. And these are the unfiltered words of young people who are reaching out around a wide spectrum of challenges, from feeling sad, bullying, feeling depressed, anxious, having relationship problems, all the way to talking about suicide. So we also have our staff or volunteer data. And so that would be data that they collect about the demographics, what young people were talking about, quality measures, our impact measures, our evaluations that we put to our data systems. And then we have our system generated data. And that is our contact center data. So when do calls come in, or chats or texts, call recordings or transcripts, queuing. So how many are coming in for French versus English versus other languages, workflow, what resources are we providing? So we have the largest database in Canada of services and supports, about 25,000 that we can refer young people to. So we can collect how often are we referring to particular services, and when are there gaps? There's not a service that a young person actually needs. A lot of our work over the last few years has been migrating all of this data and all of these data sources to a cloud-based data warehouse so that we can build the foundation that we need to really build the future for our AI and ML work. We have lots of different platforms and infrastructures behind all of these services. And so we are trying to pull all of that data, both structured and unstructured, together in an environment where we can analyze it and compare it. As was mentioned earlier, privacy is critical when we start thinking about this data. How is it stored? Who has access? How is it scrubbed of identifying information? There's a lot of conversations around, does data ever leave Canada? Does it go through the US, for example? All of those we have to be thinking about. But equally, and again, this was brought up a little bit earlier, what is it that our equity deserving populations not only need and require, but deserve? And so how do we think about OCAP principles for Indigenous users? How do we understand that the data that comes from our Indigenous users belong to Indigenous groups and communities? How do we share that? And then we also talked about some of these questions around ethics, how data could and should be used. There's a lot of questions about whether people in crisis can actually consent, given that we all know we don't read any of the consents we get when we're not in crisis. So can you consent when you are reaching out to a service in crisis? Can you consent when you are a young person? There's a lot of different ethical questions that we have to work through as we think about how can this data all be leveraged and used. A lot of what we do at Kids Help Phone, we have built up councils of equity deserving populations. We've had our Indigenous Action Council for about 4 years that is made up fully of Indigenous people, half of whom are youth. We also have a Black Youth Council, and they help inform the decisions that we make about equity deserving populations, and also help us look at our data for bias. Where are we potentially building tools or understanding our data in a way, or asking questions in a way that is biasing what it is that we're getting? So that work is so critical, because I know someone mentioned earlier, the data you get in is going to be the basis for the kinds of tools and the quality of the tools that you can build moving forward. So what have we done with this? Well, one of the things we've done that is not AI or ML, but is just cool, is that we have published a subset of our data that is available to anybody in Canada to look at. We published this last year. This is an aggregate data from our conversations. And last year we published it. We just republished it about a week ago. It is updated daily, and you can look at it by issue, by province. You can break it down by some demographics. But as we were talking about some of those sort of ethical questions, it's also important to understand you can't break it down by all of the ways you might want to, because we we went into this conversation about what data we could share with young people to say, how do we ensure we're not reinforcing stigma? How do we ensure that we are keeping young people feeling safe and that their information isn't being shared? So for example, ethnicity is not shared on this, gender is not shared. But if people are interested in what young people are talking about and at least a snippet of some of the data, you can see it on our website there. One of the first ways that we started using our data was to build a chatbot. This chatbot is using Dialogflow, the Google Dialogflow NLU platform. And the purpose of this is that young people come to our website or gateway, and there's a ton of different services and supports. And what they were saying to us was, how do I know where to start? And so we built this to help young people connect with our resources, but also to our one-to-one or many-to-many services. Since it launched, it has had about 100,000 conversations, and it has connected young people directly to our counseling or texting crisis support about 5,000 times. In English, the conversations that are most prevalent are suicide and depression. For French, it is relationship issues and suicide. And equally important, it has about an 83% rate of understanding. What is important about this is building it is great, but you constantly have to be reviewing it, because the last thing you want is that drift to start happening. And it will happen very, very quickly if you're not consistently testing it. Every time we add new content or information or services, we have to make sure that we are adding that to the chatbot, because we don't want someone to come and use this and be incredibly frustrated that they are trying to talk about bullying and getting resources about gender identity. And so this is one of the ways that we have been using our data. Another thing that we have done, this is an example of our texting service that uses technology that allows us to triage conversations. And I know some of the speakers before were talking about how do we understand suicidality. So at Kids Help Phone, when somebody texts into our service, based on the words that they use in that initial text, they are triaged to the top of our queue. And so you can see in this that the conversations that are yellow have been triaged above other conversations. And the interesting part about this was when we first started this process, we thought that maybe what we should be triaging are things like suicide or words like die. And that was not true. The thing that makes it most likely that we are going to have to conduct an active rescue or an emergency referral for a young person about suicide is when they discuss the means. So when they talk about overdose, they are 3 times more likely to need an emergency referral. Pills or jump 2.5 times more likely. And so we use this information and that 28 million messages that I was talking about earlier to help us understand how do we triage, and then we consistently are reviewing that to ensure that the triaging mechanism is working. And equally, are we having bias in how we're triaging as we think about those equity deserving populations? I'm going to just touch quickly on the future, because we have really just scratched the surface of what we know we can do. As we are working to build this cloud infrastructure with all of our data, we know that there are huge ways that we can leverage this data. Always thinking about intersectionality, about barriers, about reducing stigma. And some of the products that we are working on right now are a chatbot for when young people are in queue with our chat or our texting service. So what can we do while they're waiting in order to bring down their distress? We're looking at how we could potentially build a recommendation algorithm for our frontline staff and volunteers, because we know that certain phrases that are used about certain problems seem to have a better outcome when we look at transcripts and then we look at the outcome data. How can we look at prediction engines for triaging people to the most appropriate service? So maybe speaking with a volunteer crisis responder is not what you need right now. You would benefit more by speaking to a professional counselor or by going to the peer support service. And then equally important is, how do we build tools where we are in the places that young people are spending their time, instead of consistently requiring that young people get off of their favorite, WhatsApp or Instagram or Twitter and come to us. And so how do we think about that in terms of privacy? How do we think about that in terms of AI and ML? But there's a lot of work around, if young people are spending their time on Twitch, well, then Kids Help Phone needs to be there. So that is going to be the end of my presentation. Thank you so much, and I look forward to questions and the conversation.
Thank you so much, Elisa. That was wonderful, and it was so important that you highlighted the importance of data and infrastructure, but also gave us those tangible examples through, how AI could be used for chatbots or triaging tools. So thank you so much. And I will now, I have the privilege of introducing our next panelist, Dr. Patricia Lingley-Potty, who is the co-founder, CEO, and president of Strongest Families Institute in Halifax, Nova Scotia. She obtained her PhD at Dalhousie University, where she's an assistant professor in the Department of Psychiatry and a scientist at the IWK Health Center. Dr. Lingley-Potty has 30 years of pediatric nursing experience with expertise in research methods, scale development, and the conduct of randomized clinical trials. Her research work centers around harnessing the advantages of technology to deliver accessible and timely distance, evidence-based interventions to children, youth, adults, and families. Over the past 20 years, Dr. Lingley-Potty's expertise has been founded on innovative e-system development for online services and design for improved organizational efficiencies, development and evaluation of evidence-based programs, outcome evaluation, telephone and virtual coaching development, training and digital system integration, client-centered care, system scalability, scale development, military families, and clinical trial design. As a scientist at the Isaac Walton Killam Center in Halifax, Nova Scotia, and assistant professor at the Department of Psychiatry at Dalhousie University, Dr. Lingley-Potty continuously seeks opportunities and new research partners to develop new programs and to utilize, customize, and enhance the IRIS platform. That's the Intelligent Research and Intervention Software, which is a sophisticated e-health information management system that she helped develop, and it provides innovative solutions to bridge the access gap. Dr. Lingley-Potty has 32 publications, and she's received national recognition for her social innovation as a co-recipient of the 2012 Mental Health Commission of Canada Award, the 2013 Ernest C. Manning Award, the 2017 Governor General of Canada Innovation Award, the Canadian Alliance on Mental Illness and Mental Health, a Champion of Mental Health, Innovation 2019, and most recently, the recipient of the Digital Health Canada 2020 Women Leaders in Digital Health Award. I know we are going to have a fantastic talk, so welcome, Patricia, and the floor is yours.
Well, thank you for that amazing introduction, and thank you everyone for joining me today and inviting me to present. So I'm just going to share my screen, and it's always interesting when I hear other people leading up to my talk on the panel, because there's just so much similarities in what we do, and especially with our similarities with Kids Help Phone. Hopefully my screen will advance. It seems to be stuck though. Huh.
I see the main page.
Yeah. Very interesting that it's not advancing. I wonder if it's I've been having issues with my internet, so let me just stop my video.
Okay.
See if that helps.
wonder if our tech support individual can help out, maybe.
Oh, here we go. Here we go. Okay. All right, so just to give a bit of a background, so Strongest Families is a nonprofit, and we're pioneers, as is Kids Help Phone, in virtual, but we are focused on mostly cognitive behavioral informed care using telephone support coaches as well as technology. And we're grounded in more than 20 years of social science research that provides a bilingual service. It's a system of care, actually, that was designed and based on best science, primarily focusing on children, youth, and families, but also into the adult programming as well. Our clinical trials actually showed that our coach programs overcome diagnosable mental health disorders within 5 months. And that's using highly trained paraprofessional coaches, and that's very compelling outcomes. We were quite excited about that. And so our services, although still today are not quite equitable across Canada, we still are reaching about 13,000 Canadians annually, and we are primarily government funded. Strongest Families is a really good example of a e-mental health intervention research project that has been successfully scaled over the years. Co-design, as Elisa has said, for Kids Help Phone, it is a fundamental tenet of Strongest Families ever since inception. We wanted to make sure we use multiple methodology to use our users' feedback to inform what we do, so we can be ensured that we're meeting their needs. We're unique as a nonprofit because we do own and operate and maintain and innovate our own proprietary software, Iris. So 20 years ago, we had a vision of creating a distance system of care that was co-designed, engaging, an intervention system that was accountable, because we were using non-professionals at the time to deliver cognitive behavioral informed care. And so 20 years ago, it was a very new thing to do. And so it was quite a journey. And so why do we develop a purpose-built system? Well, if you can think and put yourself back 20 years ago, most of the existing platforms were really from the education end of things, and mostly, learning management systems, not designed as an intervention nor a research platform. Not to mention the limitations that we were facing in our design when it came to dial-up service. I think that's dating me, but that was quite a complicating factor. We couldn't really innovate as much as we wanted with that type of limitation. But we knew we needed to develop a pretty sophisticated system that included elements beyond an LMS. So a coaching interface that hosted our evidence-based coaching scripts that integrated with the user interface to make sure that our coaches were able to inform the care as the client was progressing through the program. But also we wanted a staff management system, a workflow management system, so that we can monitor performance and make sure that clients were tracked. We also wanted a system that automated a lot of administrative tasks so that our coaches were spending most of their time on the phone and not doing administrative tasks. We needed an embedded quality assurance process to make sure we are accountable for the coach's work and that it was consistent services delivered between coaches. And we wanted a report generation system that we could take this real-time data and quickly analyze it and see what the impact per coach, per client, and overall outcomes were. So, sounds really easy, right? No, not really. It took us years to co-design, validate the system, and scale it. You're going to see that we've been through several iterations over the years. So this is our technical journey that I'll just walk you through a little bit. So it's been certainly an exciting journey, but not without its challenges. From inception, it's been a persuasive design. So it's tailored to meet the needs using basic, but rule-based AI, the if-then type of algorithms, if you will. So we've had several iterations of Iris. We've been through several different programming languages. We've tried to outsource, and then we brought it back in-house, and we've gone back and forth several times. There's been a lot of trial and errors. The main challenges that we were facing in the first decade was the cost of the programmer time. every time we built a new program or had a new research program coming along, even though it followed the exact same fundamental concepts and workflow, we had to redesign every single program. So that it was not very effective or efficient, I guess I should say. So keeping up with advanced technology was also a problem, as you can see. Now, another thing that I was always bothered by was when I wanted to make a quick change, when I went to my programmers and they said, and they use the term, Trish, it's hard coded, I would cringe, because I knew that anytime I wanted to make a change that would be improving the technology, it would be very difficult and costly to go back to the original architecture and make that change. So there's a lot of work, a lot of more expense to do that. So we knew by the year 2010, we really needed to advance the system to be more generalizable, more agile, more adaptable. And so now we have Iris. Iris does use the rule-based type of AI, but what that does in some examples would be the tailoring. And we're confident in the tailoring because we use our skill-based information. And so Iris will expose like tailored responses to the client and coach data, like texts, that are embedded into the sessions. Each session as they go along, it's customized to meet their needs based on the data that they input. Even our media, our skill-based videos and our audios are also triggered by the client data throughout the session. So it's based on smart technology. We also have several validated outcome measures, pre and post, that we use. So and a lot of screening data. So we're able to provide very quick outcome reports to make sure that our quality is maintained. The really neat thing about this new version, the HARP 5.0 Iris version, is it does not require a programmer to make changes. I have content configurators who do not have programming background, and it's easily trained, and so it's really great from an adaptability perspective. Especially during COVID, we were able to easily adapt the programs. Now, that gives our programmers the opportunity to focus on security, maintenance, and continued innovation. So when it comes to some of the advantages, I'll just touch on some of those. We do have control over the rule-based AI in that we know we can trust what goes into the system. Now, for SFI, it's really important for us to have that type of control, again, so we can adapt quickly and respond, especially during COVID. So rule-based AI does provide that, and it provides that client customization, and we can ensure our safety recommendations are consistently triggered to the clients, but we could do so much more. And I think about some of the conversations we've had today, because we have so much big data. With our embedded quality assurance, we are able to maintain that quality of care. We're able to drive down organizational waste so that our coaches are on the phone where we want them to be. It's a cost-effective platform for our Iris licensees because, again, it's easy to train a content configurator. And for our clients, it's a very easy way to navigate. It has been co-designed, it's been built with them in mind, and it's a step-by-step approach. So it's not a generalized wellness platform where it's sometimes difficult to navigate. It's very much a prescribed evidence-based programs. I guess the thing that I'd like to conclude with are, some parting thoughts on some of the challenges that we've been experiencing, and I'm not sure if it resonates with anyone else here today, but there has been a lack of funding support for e-mental health technology advancement, especially as a nonprofit. With the rising cost of security, our cyber insurance is higher, our annual security audits are more expensive, and there's a push towards ISO requirements, which is quite costly to undertake. I think it's also really important for government to consider infusing more investments into technology to make sure that we're able to support these transitions from research to practice, to make sure we're able to support the sustainability and the continued innovation of evidence-based platforms like IRIS. I also do believe that there's great potential for machine learning or natural language processing to enhance care, especially with systems like Kids Help Phone and Strongest Families that has so much historical evidence-based data. If done correctly within a research framework, I really believe that we could enhance customization of care using these types of advanced AI technology to further encourage skill use and acquisition, and making sure that we're able to change behavior in particular real life situations, and that would hopefully lead to improved outcomes without real life interactions. It is quite a competitive landscape for e-mental health solutions. So I'm going to put on my my researcher's hat, and there seems to be a trend post-COVID for funding e-mental health solutions that may be high volume, low cost, low intensity, but we need to ask our questions about what do we know about the evidence? What do we know about the effectiveness? Or what do we know about the digital attrition? Are people completing the whole programs as designed? Because if not, we're going to see that ever evolving exacerbation of underlying mental health conditions if we don't get this right. There is still a scarcity on the research end with the literature on the effectiveness of mental health solutions using AI. What has been reported are fairly low sample sizes. So how do we know if a system is beneficial or if it's possibly harmful? I think back to what Andy said, the right data getting in is important for the output. So we really need to get this right. If machine learning algorithms are developed outside of the clinical or intervention, real life type of context, how will we know if it's beneficial to actually improve well-being? How do we know if it will in fact help people? As Niraj had mentioned, we need to build trust within the AI data and world. And part of the way we can do that is to have really robust research strategies and build the evidence, I believe, is the key in my view. And again, we really need to be taking caution when we're making decisions now about what solutions we invest in. We want to make sure that we invest in services that are going to advance and improve the well-being of our Canadians. So it's really critical for us to make sure that we have good, solid evidence around the advancing systems that are coming out. Those are some of my main advantages and challenges that we have gone through. So I'm really looking forward to our question and answer period. And thank you again for inviting me today.
Awesome. Thank you so much, Patricia. Those were some really great insights about the kind of importance of co-design, no matter how long it takes. And also what stuck out to me was just moving from hard coding to content configuration. I thought that was really kind of opens up and makes it more accessible to build AI-based applications or technology in general. So thanks for highlighting that. We'll get to questions in a moment, but now I have the privilege of introducing our final panelist for today, Rohan Mehta, whom I've also had the privilege to work with. So Rohan is a patient advisor at the Center for Addiction and Mental Health, and in the past has held the co-chair position of the Clinical Patient Advisory Committee. Being a vocal mental health advocate, Rohan dynamically contributes to supports quality improvement work, as he strongly believes that incorporating patient perspectives and diverse needs is key in building and sustaining viable mental health care practices. He has participated in numerous studies at CAMH while also being a co-applicant on a number of research funding applications, including over three CIHR grant applications, some of which have then moved on to get funded. Over the past 21 months, Rohan has been an active member and patient partner in the Brain Health Data Bank Initiative, that supports the Crumble Center for Neuroinformatics and took a role in leading the co-design of a patient-facing dashboard and My Mind chart. He currently sits on 2 steering committees, 1 working group and another sub-working group, and is thankful for all the exposure he's received on how modern big data and AI techniques, such as machine learning, can potentially revolutionize mental health care and create favorable treatment outcomes in Canada and perhaps across the globe. Rohan's tryst with mental health and addiction took shape about 14 years ago when a series of life setbacks and challenges started handing his mind simultaneously. The societal stigma, shame, and cultural background precluded Rohan from seeking any support for the longest time. When things exceeded his high tolerance thresholds, Rohan finally agreed to seek medical help about 4.5 years ago and was officially diagnosed with acute mental health conditions. Today, as his recovery journey steadily progresses further for the better, Rohan is grateful and feels fortunate on being initially treated by an understanding family physician and then by an equally caring and compassionate advanced medical and support staff at CAMH and Hopeless Me at the Mood Disorders Association of Ontario. Rohan holds an MBA degree from New York City and has worn multiple hats in his professional trajectory that also includes survival jobs to make ends meet. He's a super fan of Mother Nature and the universe and enjoys volunteering for meaningful causes by believing in receiving through giving. What an amazing group of individuals we've heard from and will hear from today. And so welcome again, Rohan, and the floor is yours.
Thank you very much, Lydia, for your kind introduction. I really appreciate it. So next slide, please. Who am I? A fellow human who had a mind, but unfortunately, I lost it once upon a time as a result of being increasingly vulnerable to a mental health crisis. Today, hats off to the care that I received at the Center of Addiction and Mental Health and other community clinics in Toronto. The mind has been found and is steadily recovering from a fragile to an agile state so as to make a sustainable impact in our community in partnership with you. I've been a patient at CAMH, as Dr. Saquera said, since 4.5 years. I've been a patient partner on research studies since March 2018. I was feeling worthless and hopeless for the longest time in my life. And after feeling a medium risk suicide attempt, also, I decided that I have to start healing and feel worthy. And I decided to partner on research studies. I worked with Dr. Jillian Strudwick. She actually found me when I participated in a series of focus groups for her team. And that's how my story began and my participation started deepening. I participated in various research studies, CIHR planning and dissemination grant, and some of the relevant ones have been included here. I'm a partner on the patient portal study, open note study, and I was also extensively involved in digital interventions to support population mental health during COVID-19. So there was a toolkit that was built by the digital health team at CAMH, and I was a patient partner on that team. And another team that I have been working extensively with is the Brain Health Data Bank Initiative, which is a part of the Crumble Center for Neuroinformatics at CAMH. I've been a former co-chair at the Patient Advisory Committee at CAMH, and currently I am supporting a lot of quality improvement initiatives at the Center of Addiction and Mental Health. Next slide, please. So what is the why of an advisor? Why do we want to be made a part of the process? To me, I personally believe like patient empowerment is the key. And I started participating actively within the hospital setting. That was the only interaction that I normally have for the longest period of time. I started making observations during my group therapy sessions. And there were a lot of people from different walks of life. And what I observed was each one of us who were seeking services, we thought differently. There was different thinking patterns. However, we were still humans, and there is a similarity in our differences. We yearned for solutions that encompass empathy. There was a sense of common humanity. So during the care journey, I recognized the importance of patient perspectives and diverse needs as they enable healthcare professionals to embed outcomes that are right for patients, thereby helping build viable and sustainable practices. Understanding patient choices and unique needs while building solutions will result in shared decision-making, thereby empowering patients to take joint control of their recovery journey. I believe empowerment delivers enrichment to the patient-hospital relationship and has a huge potential to create a win-win situation. Next slide, please. So mental health, technology, and patient, what I call them is just like the mind, body, and soul. They are the three musketeers. In today's disrupted times, mental health, technology, and patient are like those three musketeers that cannot live with each other, but most times they cannot do anything without each other. Adopting and enforcing meaningful technology change is never easy, especially in intricate fields such as mental health. How can patients feel more secure about their data being kept confidential? A lot of previous speakers did mention about the safety, trust, and privacy aspects, and this has been a concern for all the patients. I've been a part of a lot of committees, and the main patient advisory committee at KMH, all my fellow colleagues bring up the topic of safety, trust, and privacy. So how can we adopt a meaningful technology change that addresses all these needs? A lot of clients and patients at the Center of Addiction and Mental Health are worried about the consent. They want the consent to be really crisp and clear, nothing more than 2 pages, because none of us frankly read it. So, and also this is an observation that I had made was a lot of clients are willing to share their personal health data as long as it's used for nonprofit purposes by universities or for research. There is a lot of apprehension when it comes to the data being exploited for profit purposes. However, I really believe it's fine if it's used for profit purposes, as long as the 80-20 rule applies, as long as the 20% of the profits get reinvested into mental health systems to address what I call as the social determinants of mental health. Next slide, please. So mental health, technology, and patient. This is the value addition. Advancement in meaningful technology has already revolutionized our physical healthcare outcomes in terms of enhancing the quality of human life. If you see, technology has increased life expectancy in North America and around the globe in the last couple of decades. However, mental health is one such area where the reach and impact has been limited. Digital interventions can ensure that high quality mental health care remains accessible to a broader population, as it adds convenience, it reduces ridiculous waiting times for some services, and there is also flexibility in scheduling in some cases, because virtual consultations can be very effective in remote areas and where access to services are not easily available. And I also believe that digital health can help eliminate perceived social stigma that is associated with receiving mental health therapies. So when people are receiving therapy using virtual means, their identity can be sealed and they will not feel the stigma to an extent that people feel when they receive in-person services. Next slide, please. So I participated, as Lydia mentioned earlier, I participated in a co-designing patient-facing dashboard project. This was way back in the last quarter of in the last quarter of 2020. I was involved in co-leading the dashboard along with J&J. What is J&J? It's not Johnson & Johnson, it's Joanna and Joanna. One Joanna was an intelligent and hardworking OCAD master student, and another Joanna was a brilliant project supervisor who guided us at every stage. I was responsible for gathering qualitative requirements by conducting 6+ interviews, and the interviews included patients, their family representatives, and healthcare professionals. I was able to, my lived experience helped me forge a genuine connection with patient and family interviewees and helped us interview in a manner that solicited quality findings, supporting a dynamic patient design. What did the participants want when we first started interviewing? The participant actually wanted a dashboard that could help them understand the correlation between the progression of their symptoms, the external events they face, their behaviors, and the medicines they're taking. They also wanted a tool that gives an analysis of data and not just statistics and graphs. Finally, some of the interviewees pointed out they wanted a dashboard that could be used as a communications tool to take action around illness and care treatment during and outside of regular appointments. So the dashboard that you see on the screen, this is a mock-up that the student had created based on the findings from our interview. So there would be a section when the dashboard goes live. On the left-hand side, the diagnoses of the patient will be there, the treatment care plan. On the right-hand side team, the entire care team would be there. The patient would have an option to make an appointment. All the available resources would be listed, and a call to action will also be there if suicidal risk occurs. Next slide, please. And this is also another markup that was created that shows the trajectory of mood and anxiety. The patients can make their personal notes so that it helps them to have a meaningful dialogue with their care providers, and doctors' recommendations also would get captured in the dashboard. Next slide, please. So what are the collaborations that I had with the Brain Health Data Bank team? I'm really grateful to the KMH Patient and Family Experience team for involving me in the Brain Health Data Bank project. The team has been really helpful, and I've been made a part of the steering committee, the scientific advisory committee, the working group, and one sub-working group. I ensure that a patient voice gets incorporated in all those committees and our viewpoints are raised and heard by decision makers. Some of the highlights that I wanted to share is I was given an opportunity to actually participate in the Cambridge Board of Trustees virtual retreat. Dr. Sean Hill, who is the scientific director of the Brain Health Data Bank, he encouraged me to participate and give a presentation on open science and data. So I was able to present a patient voice to the Board of Trustees that included the KMH CEO and president. So I was really grateful that patient voice was getting included at all levels across KMH. And secondly, I also participated in the My Mind Chart submission towards the KMH Innovation Expo 2022 competition. So our submission, the My Mind Chart was very similar to the dashboard. It's just an offshoot of the dashboard. And our submission was actually selected out of 45 submissions towards the semi-final stage. And I was able to deliver a pitch with a senior doctor. Unfortunately, we did not make it to the finals, but there are always lessons learned, and we will make an attempt again next year. Next slide, please. So lastly, why listen to patients and what do they know anyway? This is a common question that I used to get early on. Well, I would like to say that when patients are motivated to participate in co-research activities and their appropriate inputs get embedded, then the outcomes become meaningful, and there is radical acceptance of research solutions in the greater community. So all the solutions become evidence-based. Additionally, I feel research investments in artificial intelligence will become truly valuable and provide a bang for the buck in funding when patient expertise gets leveraged in transforming care, building capacity, and delivering the much needed hope, which is the mother of all solutions. Lastly, I would like to end by saying that today we are living in times of increasing technology, and technology is disrupting everything. So if the time is yours, by yours, I mean all the healthcare professionals working in the sector, then together in partnership with patients and families, ours will be an era. We will leverage artificial intelligence and technology to deliver solutions that will ensure healing flows like a flood, not just for you and me, but for us and we. So I am in it to win it. My question to you is, will you be there? Thank you. Over to you, Lydia. Thank you, Mercy Before.
Thank you so much, Rohan. And maybe we'll ask you to stay on because we're going to bring all of our panelists back to have that discussion. And in the meanwhile, I just wanted to say we are all rooting for your next win, Rohan, at the Innovation Expo. And thank you so much for bringing forward the importance of co-design and also the voice of those with lived and living experience. And what I really liked was that 80-20 rule for thinking about consent or thinking about where you would give your consent. It's something that I might kind of use for my own self. So I think we have all of our panelists and our keynote as well. So we've had lots of great questions come in, and maybe I can get us started. There was one about education. So someone was asking whether there were any skill sets that you would recommend clinicians equip themselves with to participate in machine learning or AI projects. I know there's a lot of discussion about interprofessional collaboration. So I don't know, Neeraj, I know your company does a lot of education, or Andy, if you wanted to get us started, and then I invite everyone else to chime in as well.
Maybe I could kick it off. I answered it with a little text in the chat box. Clinicians don't realize how welcome the ask to be involved is. Clinician engagement is absolutely important, as is people with lived or living experience. As Rohan's presentation was fantastic. I suggested there are some ways in, if you really want to do some heavy lifting as a busy clinician, you can go to a couple of Coursera courses that are offered on basics for machine learning and AI that are quite accessible. They take some time, so you have to actually want to do that. They're interesting and well run, and they're free. If you want credit, you pay a little fee and you get a certificate for having completed them. But it's about building the skills. And you don't really need much skin in the game to get into a conversation with an AI team, because the expertise of each element is super important. An example is talking to child psychiatrists about billing codes. Billing codes could be an access to a diagnosis, but actually the habits of clinicians in the health system, without any criticism, is just normal human behavior. You go the path of least resistance. So you use the most convenient, most practical billing code, and it doesn't contain the detailed information you want, because some of these codes are real catch-all. Unless you speak to a specialist group, you'd never know that. And being in that conversation, everybody who's a different kind of specialist, including people with lived or living experience, you gain stuff by osmosis. Everybody comes together. It really is a community thing, and everybody's welcome. It's amazing how the magic works if you just reach out. I suggested connect with a local group that does something that you're interested in. If there's no local group, go provincial. If there's no provincial group, find a group nationally. You make that connection. You'll be amazed by how well it is. And the principles of collaboration are the same. If you reach out and somebody is too crusty or busy or curmudgeonly to respond, you probably don't want to work with them anyway. There are plenty of really energetic, enthusiastic people who are just totally on board. I'm listening to Rohan's really great presentation. There's an example of the kind of enthusiasm that's just infectious, right? The connection, once you make it, it just takes off. Thanks.
Sure.
Sure, I'll comment as well. Lydia, and you asked about the education element. Obviously, and I'll support that there's a large room for education for all of us. The world is moving very quickly, so awareness of AI and machine learning, the technical aspects and awareness of the opportunity, as well as the trust and the guardrails I was speaking of, is really important. You know, there isn't anybody in the world who's an expert on this topic because it is moving all the time. So we all need to keep going on education. I would just say on the flip side, though, that don't feel like you need to be an expert at machine learning and AI to be knowledgeable and move forward in the right way and with the opportunity. So, you know, there really is, as was shared earlier today, some models and understanding of machine learning that are important, but don't feel overwhelmed by, you know, it's so intricate and technically advanced, because it is, but you need to understand how it can be applied and what are the nuances that are relevant to you. So, you know, we do custom education programs. Learning is really important, but I think you'll find that having some awareness both on the technical opportunity, but also the application and guardrails would give you confidence to move ahead and keep the education flowing as we go along.
Certainly, I think that's a good point. We've talked about the importance of data and knowing the data, and I think, you know, clinicians are the, you know, keepers and documenters, and so they really know the data best. So that's a good point to kind of think about when you want to work on AI and not necessarily having the entire skill set. Over to Yusuf. I think he has our next question ready.
Yeah, just to chime in as well. I know that we, especially at the Mission Institute, UHN, the Vector Institute, we always deal with clinicians asking a lot of similar questions. And we do actually have a training program where we do educate clinicians about AI and healthcare and machine learning. It's called the Clinician Champions Program. So I definitely encourage everyone to just look that up. And I think it would be very beneficial and help a lot of people transition into the new stage of healthcare, for example. So another question that did come up is from the equity perspective, is that a lot of computing is done in English. How do we process data in another language in terms of equity, privacy, and how do you deal with cultural nuances with the way people say or type certain things? And maybe we can start off with Elisa to kind of describe how Kids Help Phone kind of accommodates these different types of cultural nuances through NLP.
Yeah, so I would say I don't have any great answers. I am one of those people that I am not a data scientist. I am not an expert in AI. And so I really loved the way we were talking about how other people lend their expertise, and particularly for us, our frontline staff and volunteers are critical in all of our learnings. I would say that from Kids Help Phone, we have way more data in English than we do have in French. So our ability to understand and to build tools in English is stronger because we have a larger data set. And so what that means is that we consistently have to look at, okay, well, how much data do we have, for example, in French? And then how do we do those partnerships with young people with lived experience, with young people from all sorts of different equity-seeking groups across Canada, so that we ensure that we are, even if you have the data, you want to have those young people, for us, involved in every part of it. I think the other piece, and I think it was in one of the questions as well, is how do you kind of audit your processes so that you ensure that bias isn't coming into it? And that is a really hard thing. It's something we're constantly looking at Kids Help Phone. And part of that, so for example, when I was talking about our triaging, well, at the end of the day, we are able to see how many emergency referrals did we make in a given day, week, month. And then we can lay that atop of how many of those conversations were actually triaged. And we can lay that on what were the backgrounds that those young people said that they identified with. And so we're able to start understanding, for example, young people who come and say that they are from the Caribbean or African diaspora. and that we needed to do an active rescue with, or who talked about suicide, did the triaging actually work and were they triaged? But it does take a huge amount of work. It takes a lot of understanding. And I think most importantly, it takes commitment that you actually believe that we have to be building products and services that really meet the diverse needs of young people or people across Canada. If you put on blinders, then you just go, oh yeah, I'm building new things, that's cool. And you very easily can forget, is it working for young people in remote areas? Is it working for 2S LGBTQ youth? And so you have to have a commitment as an organization to say, we're going to actually look at this. And I'd say from a charity, I mean, we don't have a large staff. We don't share our data with any other organization for all of the different reasons that we were talking about around privacy and ethics. So it is a process of us being able to build up our data team and our analysts to be able to review that data with a real eye on, are we serving young people, and are we serving young people from every single group across Canada? It's a long-winded answer, but that's part of what I'm saying.
Fantastic. That's exactly what we're looking for. I see that there's 2 hands up as well, but Patricia, I saw that you were nodding your head and you were very enthused with what Elisa was saying.
Well, yeah.
Comment on
So
that as well?
it is such a difficult area, and I resonate with what Elisa is saying, especially from a charity perspective. When we, we've co-designed with various different lived experience backgrounds in everything that we've done, but with the language differences, it's very difficult to. I mean, you have to think about the amount of resources that it takes, and the amount of information. So from a system of care that was particularly designed in English, 20 odd years ago, we're still innovating as we go. We have multiple programs that are, 12 sessions long with videos and audios that all need to be transcribed into French, but also it's the architecture again of Iris. It was built primarily English. So even for us, when we started translating everything into French, just one other language, we still had to go back to that architecture and make the hard-coded English tabs and everything else that's hard-coded in the screen or the interface. It required a lot of resources. And as a charity, if I don't have an infusion of funding to support that, it's very difficult to keep us moving forward. I have to agree with Elisa. When I look at our data, our Francophone population is very underrepresented. It's possibly because the way we function with our government contracts, we typically get direct referrals from the community mental health centers, and I feel that we don't have equal representation across all of our marginalized populations, to be honest. So we do have a lot of work to do, and I don't have all the answers either.
Fantastic. I see, Andy, that you had your hand up, and then
yeah, I think Niraj wanted to. I'd love to hear what he has to say first, if that's okay.
Yeah, let's go to Niraj first.
Yeah, no, happy to. I'll start with the obvious. People are biased. Technology is biased. The advantage we actually have with technology and AI is you can measure it. So if you think about the training data that's going into a model, and you think about the target data of who you're going to apply that model to, if there's a disconnect, then you can measure it and at least have that illuminated. So clearly, when you talk about, I mentioned facial recognition, it was trained on Caucasian males. It worked very well on Caucasian males. Didn't work so well on people of color. You talk about voice recognition. I don't know if you have Alexa at your home, but if you have not only if you speak Mandarin, but if you have an accent, you aren't understood. Is that okay? We have this problem in our healthcare system. We have it in our society. At least with our technology, we can illuminate it, measure it, and get better. So it's a really important topic. And we don't have legislation around bias in AI. We have some privacy legislation. So we need to have some transparency on these topics so that we can apply the technology effectively, because we don't want to not use it, but we want to use it where it makes sense and where it's not biased. And so I thank you for that question, because it's such an important one. But the good news is, again, we can measure it with AI.
I think that's really important. The whole issue of bias in AI and bias being inherent in the person who wrote the code is something we're just beginning to catch sight of. And it's actually not obvious. It's not intuitive. I meant to mention, there's so many things to talk about. I meant to mention my colleague Tom Insull's new book, Healing. Tom, it's a very American book. It's all full of American kind of examples, but I think it reflects many of the conversations we're having internationally. And in the end, I like the way Tom pulls together what I think is a solution. He reminds us that AI and these digital approaches live in a human context. And when I think about the quality indicators that I put up about appropriateness and effectiveness and safety, I think, you know, in our chatbot work, we're working with Indigenous groups. Different cultural groups own their space. If we are doing things in different languages and we're doing things in English and French, we are using people who speak French naturally as the source of what happens with that part. I'm not confident that we have automated this yet. I could communicate with my colleagues in China sometimes in Mandarin. I use a translation machine. It works really well. Sometimes they're really surprised, like, Andy, I didn't know you spoke Mandarin. And I'm like, I don't, but when it goes wrong, it's awful. And you know, the risk, Patricia and Alisa, you got to get it right. There's no shortcut. For some of these things, the human context is super important. And I think, you know, Niraj, your comment about accents and cultural space, you can't just, the translators are becoming much better rendering one language into another, but the nuances, especially with youth, they kept keeping up with the neologisms that come up. I mean, I'm still catching up with the meaning of the word sick in English. It's like, it's really hard to understand some things. And we just have to keep it in the human context. It needs that partnership for the things we're talking about around human interaction. So yeah, it's exquisitely interesting and difficult, and it takes resources, but we need the right cultural groups. We need to give ownership to cultural groups. The big mistake we've made in Canada for years, internationally, for Indigenous peoples, instead of saying, here's the solution, it's like, we think we do this. Is this relevant to you? What would you like to do? How can we help get you up to speed with technology so you can make up your own mind, bring it back, and maybe we'll learn something from you too. We need to move more into that EDI space. Same with gender identity and so on. Everybody's mentioned these things. They're so important. The human element cannot be neglected. So there's a plug for Tom Insull, because I think that's where it's coming.
Yeah, and I see Alisa, you have your hand up. Please chime in.
Yeah, I was just going to say, I think it's also, we're not looking to technology to replace our frontline volunteers, our peer supporters, our professional counselors. What we're thinking about is, how does technology help us scale to better meet the needs of young people? But I love what you were saying around, you know, that there are things that humans can do. And some of the ways, for example, that we have been working with our Indigenous Action Council and with Indigenous communities is that they said to us, it's not Indigenous. You need a distinctions-based approach. So we should be talking about Métis, First Nation, and Inuit. And we have created and launched last year keywords that young people can use when they text us. And when possible, we match the texter who is texted in with the word Inuit with a volunteer who is also identifies as Inuit. We don't do that using technology. We use that by somebody manually on our platform saying, okay, you're a volunteer, you've got the little tile next to you that says that you have a particular group. We have a texter that texted in of that group. Are you free? Can we connect you? That kind of thing, technology could help tremendously with that matching. So it doesn't have to be, it doesn't have to be somebody doing it. But at the end of the day, the ability for a young person who identifies as First Nations or as Black or as a whole bunch of other groups to know that they can potentially connect with somebody else like them, they have said is of critical importance to them trusting and reaching out. And I'm not looking, nor is Kids Help Phone, for AI or technology to be able to take that away. So to me, it's really also thinking about what can AI and technology do and what should it maybe not do? And where are humans, volunteers, professionals going to be better? And there is something to be said about a warm, kind voice instead of the computer voice. And we're getting better. I mean, technology is moving towards warm and kindness all the time. But I still think that we always have to be thinking about what is it? Not only for me, it's what is it the young person gets, but it's also when we train a volunteer, what do they bring back to their community? How are we changing society by having real humans involved in this work? And so I just think that that's an important thing of thinking through, where do we want technology to be and where do we not?
Absolutely, absolutely. I think especially like the emotional side of healthcare, we always need to keep that patient and clinician interaction in check as well. But also the use of the word augmentation to augment the standard of care for patients and clinicians as well. So I think that's very, very powerful statements. I'll hand it off to Lydia for our next question.
Yeah, thanks, Yusuf. And I think that ties nicely into, there was a comment about change and acceptance, to say that we as a society accept the importance of certain things like Holter monitors to capture heart issues, but struggle to then accept a wearable to track and predict mood disorders. So I think there might be many factors that contribute to this, but I will tie this into a few questions we've had with consent that talks about, what safeguards do we have to train data and to use data for AI models, and then kind of move that to commercialization. There was a comment about PHIPAA and how it only covers data, not necessarily the models that were derived from data. And then a few other comments that talked about at Kids Help Phone, but even at other organizations, how do people provide consent, young people and adults, to use their aggregate data beyond the provision of care. So a whole lot of the kind of main themes that came up was changing acceptance, and maybe one factor that leads to that changing acceptance is informed consent done right. So I'll open up the flow. I know, Rohan, there was a few consent discussions in your talk, but everyone here, I think, touched on this topic. So feel free to chime in.
Very quickly, I'll mention synthetic data. One of the new approaches is to take data and try and simulate the structure of those data so the anonymity is really maintained. The problem is AI is so clever, you can take synthetic data, and unless you're really good at making it, you can reverse engineer it and get back the characteristics, the stuff that it was based on. But it is a big issue. It's evolving. The whole system is evolving so quickly. It's an important point.
Don't know if there were any other thoughts about, either what safeguards are currently available in Canada or what we should be doing. I see Neeraj, you've come off mute, so maybe.
I actually see Rohan maybe would
yes,
be first. Go ahead, please.
Go ahead.
Thanks, Neeraj. Lydia, I just had one point to make to everyone. When it comes to consent and privacy, this is what has been discussed in a lot of our patient advisory committees, is to involve community leaders from different from different communities. Like in Canada, especially in Ontario, like we are very diverse, right? So to include community leaders, to encourage patients and clients to donate their information and build that trust. Because what happens is, this is what I've also seen, there is only a particular segment of the patient population that is not very not worrying about giving their data. They know that there are protocols in place, there's going to be security, but a lot of people are hesitant. They are not educated enough on what protocols exist to secure their data. So involving community leaders across Canada, to ensure that there is trust mechanism in place will really help in giving the consent, because the data that we need is from everyone, from all groups of patients, not just one particular demographic.
That's a good point, Rohan. Yeah, thanks. So just the importance of education too. And that's a kind of a neat way to think about how we can involve community leaders to help build that trust. And I wonder, Neeraj, if that's something, you know, in terms of the guardrails and trust in AI, is that an approach that you've used before? Or
Yeah, thanks, Lydia. And I'll pick up on Rohan's comment. And thank you, Rohan, for that, the voice of the patient being so well spoken, so important in this. When we talk about informed consent, obviously there is, we've been struggling for some time about consent and privacy in healthcare and mental health care. And all of those elements are still of concern. When you talk about AI, there's another consent I think that we're talking about, which is the training data, the data that's being used to build the model, maybe miles away from the patient, because the models sometimes are being developed by vendors, by suppliers. We have AI coming into our healthcare institutions, whether we know it or not. It's on this Zoom call right now in front of us. It's on our phone. It's all around us. So one of the tools I would suggest is the Government of Canada has something called the Algorithm Impact Assessment. It's a simple questionnaire, and it talks about the impact level of your AI. On low impact AI, you don't want to over bureaucratize yourself to manage, too many elements. But on high impact AI, that's client facing, that's patient facing, that is of significant concern, you really should know, where did the training data come from? And when you're procuring AI, whether it's embedded or a model that you're building or procuring, you should demand some transparency on the data. And that doesn't mean transparency on whose data it is, but how they manage the data. And because you really need to know where that data came from. And it makes it a little harder because sometimes the suppliers don't even know, because there's a whole supply chain that's building AI right now. But it may be a policy that's critically important, depending on the impact of your AI, that you understand what went into the original training data of the models, because your outputs are going to be dependent on your inputs as well. So there's a few levels of informed consent that I just wanted to bring up.
thanks so much. Was there any other? Oh, Patricia. Yes.
I'll just add a couple of comments. When it comes to strongest families, we're very particular about our data and the consent process. So we do not share our data. And I've been in collaboration and communications with some of my New Zealand colleagues. And there is definitely a concern that I think is important for us to consider is, the selling of data from some of our e-mental health solutions. So I think it's really critically important that clients, when they enter, an app or a e-mental health solution, that they're aware whether their information is going to be sold to a third party. So from a consent perspective, again, it's really important for them to understand how their data is being used. The other piece, from the security perspective, we've had some partners over the time when we have our API connection with their interface, kind of ask for us to open up some outlets so that we trust the information that's coming forward. So we shouldn't actually confirm the user and the user's email on our end. And we, as a charity, we have to mitigate our risk. For us, if we do not make sure that our security is solid and we don't have open pathways, we want to make sure that we're not at risk of an attack. And so we mitigate that as much as we can with the security that we have, because it would be a reputational disaster for us if something like that happens. So, just that understanding that, sometimes it's not appropriate to, with the API connections, unless you're absolutely confident of the security there. So we need to do those checks on both ends.
Awesome. Thanks for highlighting, I think, just the importance of transparency that's come out from all of these talks. And I think we have time for maybe one more question, and then we'll close it off. We have an audience question to to close it off as well. Yusuf, do you have our next question?
I see that Elisa had her hand up though.
Oh, sorry. I'm missing all these hands.
No worries. I was just going to say, yeah, I think that we spend a lot of time talking at Kids Help Phone about the trust that young people have put in us over 30 years. And that therefore, just as I was saying, you have to go out of your way to ensure that you are thinking about how your services or your data is being used for equity-seeking populations. We also consistently think about privacy, security, and safety, and those have to be top priorities. So for our data, for example, it is non-identifiable, it's aggregate, it's scrubbed, and it's stored in Canada, and we do not share it. And so how the data can be used. So we use our data to provide insights, to build new services at Kids Help Phone, to improve our services. But I know somebody put in the chat an example of an organization that was using data for to give to a for-profit company. And as an organization, whether you are charity or not, it is really important that you put, I'm going to use your word, Niraj, those guardrails. What is it that you stand for? What is it that people expect from you? And often we are looking both at Canadian privacy regulations and best practices, but also GDPR in the UK, because often they have been ahead of where we are. And so we often have to be thinking about what are the best practices that other countries have come and already moved forward on, and where should we as a society be working in Canada to support our privacy commissioners and all of us in thinking about privacy and security, because it is a very slippery slope to go, well, my data could be used for building products that would help young people across Canada. So maybe I should do that. Maybe I should give it to for-profit company A, B, or C. And as a charity, it could help. But that isn't actually what young people expect. And so I love what you were saying, Patricia, around reputational risk. The moment that a young person thinks, oh, if I share my data with Kids Help Phone, it gets out. Or if I talk to Kids Help Phone, they can re-identify me, is the moment that they stop reaching out to us. And their reaching out to us is the most important thing. And so we see as a top priority the safeguarding of that relationship and therefore that data.
Yeah, that's fantastic. That's fantastic. Very, very, very interesting discussion. I think we have time for maybe one more question. One question, I know that we've spoken about the barriers, for example, towards deploying and implementing these solutions. And I know that funding did come up. So I wanted to ask the whole panelist group that let's say that you're speaking to someone very high up in the government and you have a scenario. What are the top 3 things that you believe should be implemented so that we can accelerate AI-enabled mental health care across Canada for patients, clinicians, and researchers as well? And maybe
I'm going to come out with a potentially surprising answer.
Okay.
One of the things we know from the innovation cycle and the innovation space is if nobody owns something, it withers and dies. Canadian government has firmly endorsed AI and cyber infrastructure. They put billions of dollars into this with European collaboration, and the Mental Health Commission is doing the AI strategy consultations and so on. I think one of the things that we all have to recognize, and it's a very difficult point considering some of the things we've talked about, particularly Niraj's very eloquent description of the need for guardrails. We need the private sector to be able to come in, take ownership, develop this in an acceptable way, and do business within desirable limits. And this needs a set of community discussions. Things need to be regulated. Canada's a reasonable place, but AI and digital applications, a bit of a wild frontier where people are trying to get around regulation. The internet is very difficult to regulate. But I really think the partnership between government, research, not-for-profit and private sector for-profit is really important. If things are going to live, they need some return, and it's not simply going to happen through the not-for-profit. That's a bit of a provocative statement. In my work, I never want the IP. I collaborate with people, and sometimes they offer me a stipend. I usually say I don't want it. Sometimes they give me stock options that I don't take. I'm not interested. I'm happy to collaborate. But it is part of that ecosystem that we have. And I think not to recognize that is going to turn government off because they're interested in economic growth and development for the public good. And it's also really necessary for someone to take some kind of ownership where their livelihood depends on this being successful in the right way. Delicate, but I push that out there for a bit of a discussion.
Very, very interesting perspective. I see, Niraj, that you're nodding your head. Love to hear your perspective as well.
Yeah, thanks, Andrew. That was a great comment, and I'll add my own kind of provocative twist. I think we shouldn't wait for government and regulation. I think government's doing some great things, and we want them to continue to steward that. But I think in the case of AI, we can't wait. GDPR took a while, and there's, Europe is maybe ahead, but it takes a long time to get these regulations right. What we are talking about is our reputational risk. And I think our reputation will suffer if we don't move ahead with AI, but we need some transparency of what we're doing. And Elisa, I think your comment was great on the Kids Help Phone example, is that, you want to move ahead and leverage technology effectively, but you want to keep trust. And so have some transparency. Here's how we're using the data. Here's what we're doing. And that from a governance point of view. I'm on the board of the Royal. We know that our reputation is everything. And so we need to make sure there are guardrails and some transparency to the public, to the Rohans and everyone. Ask the questions, and we should be able to answer them on how we're using the technology that's for the quality of care that we all want. So government and regulations coming, but we need some transparency and trust with what we can do today.
Awesome. Thank you so much, Niraj. And I think I'll kind of end with, opening up the floor for some closing thoughts. There was a comment or a question that came in to ask, what is the biggest challenge you are trying to solve in this space, and or what problem would you challenge the audience to work collaboratively to solve? So maybe I'll leave that open, and whoever wants to think through the problems. I know you're solving many different problems, but maybe the biggest one or the most exciting.
Very quickly, one of the biggest problems is a very risk-averse reactive health system. People like to do what they do. They don't want to take the risk because the risk may lead to some adverse system event. In fact, we cannot make progress without risk. Any organizational management change expert will tell you, if you don't have an element of risk, you're going to maintain the status quo, and then you're going to die. The health system doesn't die, it stagnates. We have massive economic problems with the health system. We need people to be a little bolder while staying, Niraj, within whatever guardrails we need. It's a big conversation for everybody, but we need to take some risks.
I'll make my closing comment on that if I could, which is just don't wait for the guardrails to be perfect. Put them up early, ask some questions, and have some transparency that you are considering those important guardrails. But yes, then move boldly because we have so much need in mental health care, and there's such an opportunity. It's my.
Thank you. Elisa, I think I heard you.
Yeah, I was going to say, I think there's two big things that I often stay up at night thinking about. One is the tremendous need for young people to be able to connect because of challenges that they're facing. And we have seen those large increases in demand, not only across Kids Help Phone, but across the country and in fact the world over COVID. And so getting back to that idea of building scalable solutions and ecosystems that actually can meet the demand. And then the other is, while meeting that demand, how do we stop fragmentation? Because if in fact what I am going to do is Google and find 45 different apps, or it's probably like 5,445 different apps that say that they can help with depression, or I can find 300 different services that are offering depression-related services, it's not actually doing any good for that end user. And so we have to be thinking about ecosystems that'll help young people or any person navigate to the right supports, that those supports are evidence-based and not just the cool new flashy thing that somebody's able to build. And that it's not always about that new thing. It really is about scalability, high quality, and an ecosystem that allows people to get the right care that they need at the right time. And that could be everything from an app all the way to that long-term counseling that is one-on-one that maybe doesn't use very much technology. And I think that that to me is where we need to be putting our energy and attention.
Thank you. Any last thoughts, Patricia or Rohan?
You can go ahead, Rohan, if you want first.
You go ahead, Patricia.
Okay. I'm just going to build on what everybody else has said, a combination of thoughts. For me, technology will help us progress with our scalability, as Elisa said, providing equitable access. But also, I think about some of the advancements that we have made with some of the donation support that we've received. We didn't want to be one of those organizations that had multiple disconnected pilot apps, if you will, for all of our programs. We have multiple programs. So we invested in an interoperable, completely connected app, and there's more work to do, but again, it's stalled because of lack of resource funding to support it. So I agree with what Andrew was saying. I mean, we do need that infusion of government support, that ownership. We need that collaboration. I need a technical partner. I could tell you how much money I spend on the IRIS support of my programmers and my content configurators in a year, and that will impact my competitiveness as we go forward because it drives up my per client costs. I want to look at way of being competitive so that more people have access to these evidence-based solutions that are proven to overcome mental health conditions in a short amount of time. That's, if we can get ahead of the mental health issues, we'll be so much further ahead, especially with our new generations. And I also think about the step care piece. We're investing a lot of time and energy into our step care, and to get that disseminated, so we actually have a Canadian mental health population-based approach to pediatric and adult mental health services. So there's a lot of things there, but I think that collaboration and getting the partners together and having some resource funding as well as partners to help us along the way. It's very difficult when I look at applying for the Federal Innovation Fund. There's no way I would have the resources to even apply and write for that. It's a very onerous. And so it's very difficult for a charity to get that type of funding. So perhaps the government could look at something that makes it a little bit easier to sustain evidence-based solutions.
Awesome, thank you so much. And Rohan, did you want to close us out?
Well, I just had one last comment, just building on what everyone said. I think time is now. We need to take calculated risks, as Andrew and Neeraj pointed out. And once proper checks are in place, we need to engage stakeholders, get their buy-in, and go all out and build solutions, because the mental health crisis, it's only getting worse day by day. So I would say let's go all out, and we need to act. And once all the checks are in place, artificial intelligence will be a boon, not a bane.
Awesome. I think that's a wonderful way. What I heard, be bold, take risks, collaborate, improve interoperability and navigation, but also for care in general. Well, I just wanted to say thank you to all of our panelists and our keynote. This has been such an insightful and exciting conversation. And thank you to the audience, because all of the questions really made this discussion happen. And I'm just looking through the chat and I see a few lots of appreciation for all of the presentations and for all of the conversation we've been having. So thank you from the audience. Thank you to the audience. And I will pass it along to Yusuf now to introduce our next and final presenter.
Thank you so much, Lydia. Shout out to the audience. It was fantastic and brilliant discussion. Our last presenter who will be giving the concluding remarks is Sheldon Mellis. He's a program manager with the Mental Health Commission, one of the sponsors of this event for over 2 years. And he previously led the commission's work on cannabis and mental health research, and now leads projects on e-mental health education, programming, and strategy development. So Sheldon, you now have the floor.
Thank you, Yusuf. Hello, everyone. My name is Sheldon Mellis, and as mentioned, I'm a program manager at the Mental Health Commission of Canada with our e-mental health team. So before I get into the closing remarks from this educational and very engaging event today, I first just want to acknowledge the land in which I reside and where the Commission operates. We are on the unceded and traditional territory of the Anishinaabe Nation, and it now is called Ottawa, Ontario. We acknowledge that for thousands of years, the Algonquin people protected these lands and the Ottawa River watershed. As a national organization, we acknowledge that we are on the traditional lands of many different nations. Today, a path to truth and reconciliation begins with recognizing both the stewardship and the sacrifices of First Nation, Métis, and Inuit peoples. We are committed to recognizing the errors of the past, acknowledging the challenges of the present, and contributing to new and equitable relations with First People. I hope your efforts, your work, and your journey for truth and reconciliation also does the same. So I've been very fortunate to be working in this space of digital health, virtual care, and artificial intelligence for mental health since the tail end of last year. It's been a very interesting journey to expand my knowledge and understanding on how technology continues to be integrated in mental health services and care. I'm truly amazed, especially after hearing the various presentations today, about the profound amount of work and research and investments that have been made to advance and drive mental health solutions for diverse groups and individuals. Today's symposium is a true testament to the level of advancement while demonstrating the significant strides and work underway in Canada. To better tailor and gear our AI interventions, support mechanisms, services to provide better mental health outcomes for all Canadians. Although there still remains a lot of uncertainties and queries about AI, such as what is it, who makes it, what are the privacy, security, and ethics concerns, its equity, biases, anti-racist, harm reduction lenses being applied at the points of design, development, implementation. It was truly nice to see today's presentations and discussions bringing those concerns to light, as well as those issues, but at the same time debunking some of the misconceptions and myths of AI through knowledge as well as story sharing. However, there's still a ways to go in front of, on the front of education and training and awareness to fill in the knowledge gaps seen from the public's eye, including from the users, clinicians, clients, and patients. For us to collectively have a clear picture of the benefits while understanding the risks of this type of technology. Making these efforts to fill in the gaps will result in a successful AI-enabled mental health care system. We've covered a lot of ground in the last 3 hours, where we were able to engage in a national dialogue, bringing folks together from across the nation to discuss current trends of AI and mental health care, while hearing the success stories and unique challenges of AI research, implementation, and adoption, including understanding those elements at a patient and community level perspective. And overall, this event has successfully promoted AI innovations from the research and products shared from experts in the mental health field. So I'd like to take the time to sincerely thank Andrew, Patricia, Ron, Alyssa, Niraj, and as well as the attendees for their contribution to this work and contributing to the education and the advancement of AI-enabled mental health care. So before we head off today, I would love for us to take a quick moment to reflect on some of the key learnings as well as takeaways from today's symposium. I have endless amount of notes on some major themes and topics that were brought up, but I summarized them in 3 major points, and I just want to do a quick recap so we're all leaving today with similar, if not the same, information. So AI-enabled mental health care is not a one-dimensional activity. Collaboration is key for the success of this work across professions and groups, such as clinicians, data scientists, people with lived and living experiences, including patients, and collaboration at large to advance big data for data collection and data access. As Andy mentioned, it does take a village, and we have to ensure that we are not missing the human context in this work. We also need to build trust for AI and machine learning through various means of trust mechanisms by education, building robust research strategies, and having evidence-based solutions. That also includes building guardrails, frameworks, governance, and clear and transparent consent of data use for AI and machine learning. Finally, AI drives and diversifies this access while removing barriers for mental health solutions and enhances the quality of life for many communities, cultural groups, and high-risk populations to meet the demand of mental health needs of Canadians. So it's very interesting to see the learnings from today's symposium crossing paths with the work that we are doing at the Commission, as well as we're seeing across our partners. We discovered through our environmental scan that we conducted in 2021 with the Canadian Agencies for Drug and Policy and Health that machine learning can be used in prevention, detection, diagnosis, treatment of mental health conditions. For example, through social media detection for indicators and symptoms, as mentioned by Niraj. AI has the potential to augment care, change delivery service, and improve access, as we see through Kids Health Phone triaging system. As we continue our efforts in advancing our agenda in AI-enabled mental health care, we also need to look into the future of this work and its impact. As practitioners, researchers, program developers, and specialists, we have a duty to not only develop products, but to fill in gaps in this rapidly evolving world of technology. Starting with future research for and with priority and high-risk populations, while sharing what we know with those who will be using or impacted by AI products and services. This in turn will reduce the confusion and uncertainties that we're hearing from the public point of view while improving the adoption of AI. We need not to forget about the power of capturing patient perspectives as well as clinicians for the application of AI, and create other sources for big data sets that can drive machine learning technologies to enhance care. What we continue to hear is co-creation. This is a very important element and for the success of AI, the integration, and as well ensuring that people with living experience, patients, clients, equity-seeking groups should meaningfully be involved at all phases of our work. In the Commission's continued efforts to explore how AI fits into our resources and work, we will look to our e-mental health implementation toolkit as a touch point to provide further knowledge and education around AI implementation. We discovered that there's a huge appetite for practitioners and service providers to learn more about how new technology and AI is coming into their space and how to successfully implement it into practice. We also know that there's a call for a national AI strategy to provide a strategic focus in a space in which will be a space we will consider as we move forward in producing Canada's first e-mental health strategy that will be developed in the next 2 years in collaboration with you, as well as many other diverse groups in Canada. To push the needle even further, it will be a priority in our work to expand our AI agenda with our National E-Mental Health Collaborative, with David Relger, as well as other key players in this space. Without doubt, there's a lot of work to do, so I hope today's symposium has spotlighted not only the successes of AI, but the endless amount of opportunities that lies within this field for the future of your work and your interests. So before I finish off, I just want to bring to everyone's attention that we have a feedback survey that we're going to put on the slide right now. So there's a QR code. I imagine, based on the stat that I saw earlier, that the majority of us should have a cell phone. So I'll allow everyone to take a moment to scan this QR code. And of course, your feedback will definitely support us in improving this event, ensuring that the content is meeting the needs of those who are participating. All right, in addition to that, I also want to mention, I think there's some great synergies around what we're hearing today around trust as well as transparency and understanding, getting a better understanding of mental health apps and technology. So at the Mental Health Commission of Canada, we've just launched a public review for the assessment framework for mental health apps. Your feedback will improve the draft standards and criteria for the assessment of the mental health apps in Canada. Right now, I'll share the link in the chat box, and feel free to reach out to our team if you have any questions. So the deadline to provide your feedback will be June 26th. So we very much appreciate you taking the time to provide your feedback on the assessment framework. All right, and finally, in closing, I just want to give thanks to the attendees for participating in today's event. I think the committee, the planning committee, should definitely give ourselves a pat on our back for putting together a really well curated event. Based on what I'm seeing from the engagement and the discussion and the speakers, I think we definitely hit the nail on the head in respect to the type of content that folks want to hear today. So hats off to the team at the Mission Institute at UHN, Vector Institute, and CAMH. And that concludes my closing remarks for today. And we look forward to continuing this work for the future of AI-enabled mental health care.